and it's always good to recap. So open up a fresh sheet of paper or thing and write about 10 or 15 words that come to your mind, just words, one maximum 2 words, and number it 1, 2, 3, 4. When you think of yesterday or when you recall yesterday, what are the words that come to your mind? Things that you learned, things that maybe some aha moments is, wow, I didn't know this. That's an aha moment. So write all that, right? So this is recap of day 1 and you have only 2 minutes for that. Rapid fire, go fast. Words that come to your mind when you think of yesterday. Right, that's fine. So I'm going to pick up names from here. Okay, now let's listen. Mahavir Singh. Not here. Okay. Mohit Roy.
Yep.
Yes. So read out. So you have the pleasure of reading out all 15.
I have just written 10.
Oh, 10 is
Something just came to my mind.
Okay. Now rest of you listen very carefully. Okay, this is very important. Listen very carefully. Suppose let's say Dr. Mohit's point number 5 actually is on your mind. Like you didn't have time to write it. It made a difference to you. You add it in your list. Okay, and you also have to listen carefully because the next person who I'm going to call has to only give new items, not the old ones that has already been spoken. Okay, so listen very carefully. So make notes and you should not repeat. So your mind is totally focused. Go ahead, Dr. Mohit.
So I have not written kind of just words. The first thing is enjoyable.
Enjoyable, that's a word. Yeah, of course.
Question design.
Okay. Biases.
Aims, objective, and hypothesis.
Very good.
All of them.
Yeah.
Sampling.
Yeah.
Bell's curve and normalization of the curve.
Right. Normal curve, not normalization. Normalization becomes
check whether it is normal or
not. Right. Checking for checking for normality. Yeah, checking. Very important. It's a critical thing before you start any analysis. If your data are not normal, you cannot do many tests.
Odds ratio.
Yes.
The types of studies, case control, cohort, RCTs.
Different study designs.
And descriptive study. Why not to do that?
Yeah, why not to do descriptive studies? Excellent. Okay, good. Dr. Surekha Patil is here.
She is not yet here.
Okay, Maharaj Singh. Yeah, please. So now you should not repeat what Dr. Mohit already said. Yeah. Okay, loudly, quick.
In this study, I have learned some formulation of effective research problem statement.
Okay, problem statement or constructing a research question along with the different components. And remember, you went back to your own research question and you looked, is this there, not there? Oh, let me add. Okay, now you have a map. You have a clear plan on how to write a research question. And that is the first step, opening the first door of the big fort. Remember that, yeah? Okay, excellent. Go ahead.
Second, I have learned about useful study designs.
Study designs, okay. Don't repeat what is already done. Next.
Then, writing a research proposal or synopsis, which one you have given in the afternoon session.
Okay, an outline. So let's say essential components of any presentation for a project. Okay, these are essential. Okay, good.
Then about parametric and non-parametric tests.
Parametric and non-parametric tests. What are the characteristics? Briefly, I told you characteristics of parametric data and non-parametric data. And what Dr. Mohit said is testing for normality. If they are not normal, you have to do non-parametric tests. What is the other option? You can dash the data.
Adjust.
Not adjust. T-R-A-N. Yes, you can transform the data. What's the difference between transforming and modifying? Modifying is not supposed to be done. You cannot touch the data, right?
Before analysis of the data,
Yeah, you do that. Okay, like for example, I don't think I told you yesterday. One of the common ways of doing data transformation is log transformation. There is also arc-sine transformation, A-R-C-S-I-N-E. You don't have to worry about it. And by the way, you don't meddle with, so we as non-statistics people should not do data transformation. That is all, because there are mathematical functions which a statistician will do. They are very good at that. So if you go and sit with the statistician next and say, can you check how my data are and are they normally are they normal, or would you like to transform the data? Statistician will say, okay, this person knows. Okay, and next, So how are you transforming data? What function are you using? Log transformation. Okay, good. Right. So you don't have to know the mathematics of log transformation. You don't have to know the mathematics of arc sine transformation, but to know that your data have been transformed, and then you can back transform it with your final results. Okay, please go ahead. Okay, said. Thank you very much. Akhilesh Patel is here. Yeah. Any new points, Dr. Akhilesh? New points in your list?
Can I not keep it simple? Visual presentation.
Right. Keep it simple. Yeah.
Visual presentation.
Rest of the things have been said. Dawood?
So, paired t-test.
Paired t-test. Okay.
Cross-sectional study.
Cross-sectional study. Prevalence. Okay.
Cause and effect.
Okay.
And observational study.
What about observational study? The different types.
The words.
Okay. Whatever comes to your mind. Okay. Right.
Observational study, analytical study.
Yeah.
Catalog of bias.
Right. Catalog of biases. How many biases? There are lots. You cannot remember them. Yeah. There are 250 plus biases, and I gave you a website, and that website is a live website. It's not only a list, and you can learn a lot. And please go look it up. It's very useful. And what do you do about biases? There are biases. We learned about. What do you do about it? That's our question. Anyone? What can we do about biases? You can minimize the bias by making sure our study design is right, our methodology is good, right? Starting from sampling onwards, actually starting from your research question onwards. Your research question can be biased. Right? I want to do a cross-sectional study to find out the difference between drug A and drug B. Gone. No use doing that. It has so many biases, it's not worth it at all. Okay? From your research question onwards till your publication, your editor can be biased. The way you submit can be biased. Okay? So throughout there are so many biases. Some are very exotic biases. Okay, go ahead.
Confounders.
Confounders, we briefly spoke. I didn't explain confounders yesterday. I'll do that today. Okay.
Follow-up.
Follow-up and why it is important. Yeah.
Incidence.
Okay.
Shapiro-Wilk test.
Okay, very good. Shapiro-Wilk test. What is it, by the way? that you don't ask. This came to my mind. Anyone? What is the Shapiro-Wilk test and what is Kolmogorov-Smirnov's test? Yeah.
Test of normality.
Very good. These are tests of normality. The common ones. There are few other tests also.
Pearson correlation.
Okay. So in terms of correlation, we discussed Pearson's and Spearman's correlation as well. Two common types of correlation. Okay. Very good. Okay. Last person for something new. Madhu? Madhu Mali? Yes, Madhu. Go ahead.
Sample, population and sampling.
Okay. So the difference. There's population, there is sample and there is sampling. Very good. There are three different things. Very good. Yeah.
Smart and fine.
Smart and finer. What is that for? We all should be smart and finely dressed. But what else? What is it for? Who can give the expansion for how to write an objective? What is smart? Yeah, go ahead.
Specific, measurable,
Achievable,
relevant,
yeah. Time bound. Excellent. Somebody for finer? Interesting. Novel. Ethical and relevant. So as you're writing objectives, you talk to your colleagues. Is it ethical? Is my objective itself ethical? Right? So I'm sure you've heard these stories when you attend ethics workshops. They will tell you about the Nazi crimes that who did? Doctors and researchers did. That time they did not know or they did not think enough. They did studies such as how long will a human survive if you put them in ice water? They put them. Okay, why? Because it's science. I want that knowledge. Okay, because the scientists have to then tell the engineers how to make swimsuits when they have to go in submarines. So they thought we are advancing science, but that is not ethical. You can't, because they were prisoners of war. Take them and put them. So whenever we do studies, we say, would you put your immediate family member into that study? Think about it. Okay, then, okay, so ethics is important as well. Okay, what else? Anything else in your list? T-test we briefly discussed. Okay, anything new? Please sit down, please sit down. Anything new in your list? Anybody? Integrity. Thank you, madam. Very important, right? So, right. So please don't forget those different INs over there. Oh, we've gone to vaccination program now. Okay. It's there behind. No, I was just joking. Okay. No, it's okay. Right? So we start from information and we end with integrity. And what we want in between is inspiring people. Get up from your seats and do research. And research for what? That's an important question. To benefit humanity. Everything else will fall in place. Everything else will fall in place.
Why only humanity? Plants, animals, everything.
Absolutely. Why not? I totally agree with you. Okay? Because we are dealing with research on humanity, I said that. But so by the way, in the ethical principles now, they talk about planet health. They talk about planet health. You can't do research. Thank you, madam, for bringing that up. How about a round of applause for that point, Madam Grant? Okay?
So it was Dr. Shobhana's answer to the second this thing.
Absolutely.
Why should you do research? So she has written this point.
Excellent. So that round off of the planet. So our children will be talking about don't pollute Mars and Moon at least. Okay. So any other new points? Integrity. Yes.
All observational studies are not descriptive, and descriptive studies are not worthwhile.
Yeah. Thank you. Yeah. The research question, PICOTs. Yeah. Very good. Thank you.
What did you say? Research question?
The PICOT, the different components of a research question, right? PICOT or PICOTs. Yes, anything new?
Research question guide as a study design, or objective guide as a study method, or hypothesis guide as a statistical analysis.
In the statistical analysis. Why do we need all of this? And Dr. Anupama was telling? Data and datum. Yes, it's nice to know those little things. Yes? Patient registry we spoke about, and I told each of you, think about doing a patient registry. Plan a patient registry in your own institution. It's one of the easy ones to get started, but then you need to expand. You need to have several thousands of people to actually have good conclusions, and therefore go to multi-center studies. So create registry, we did 21,000 patients, not only in St. John's. St. John's we got some 300 or whatever. With 300 you can't make any conclusions. Right? So do multi-center studies. Another important point I mentioned multiple times yesterday is worthwhile research is collaborative. We need to learn. So yesterday itself you started collaborating, right? And there's huge amount of learning there which we didn't discuss today. We'll do that. Okay. So what I'm going to do now is to quickly go through one study design, okay, which is the case control design. One of the groups is doing that. Okay, I know one group is doing cohort studies. Maybe we can skip that in the interest of time and do RCTs, right? Okay, then if time is available, we'll do cohort studies. Madam asked me to do little more details on biostatistics, right? Although we had planned it to keep it for part 2, we don't know when and how part 2 will happen. We don't know. We don't know what will happen tomorrow. Okay, so we'll do a bit of biostatistics now. I'll have to load my other slides, and we will do that maybe after the coffee break. So shall we quickly do case control designs? Okay, we'll do that. And maybe during the coffee break I'll shift this there, but for now it's all just set, so we'll go ahead. So I will sit down here and do this for you. Does anybody experience with case control study designs? Have you participated, done a journal club? Yeah? Anyone? Could you just tell us while the TV is coming on? Yes, madam, go ahead.
So, case control, we did a study that we published in a very high impact journal, which was, we found these patients who had, I'll just call it liver disease. I'll just call it
liver disease. Yeah.
To simplify the things. So, we had these liver disease in pregnant women.
Yeah.
And we wanted to know the outcome in pregnant women.
Excuse me. Just come. Pointer. Yeah, please go ahead.
You see, we could not take pregnant women as controls. So we took the other liver diseases as controls. In women who were not pregnant.
Right.
To find out. So we did a 1:2 case versus control. So for every case with liver disease who was pregnant, we took 2 controls and tried to find out what was the difference in the 2 kinds of disease. First of all, it was difficult because
single center or multi-center?
No, this was single center.
How many patients totally?
About 75 patients and 150 controls. So
Right.
because this disease is rare.
Right,
So
right, yeah,
we
absolutely.
don't know other people, and this was Budd-Chiari in pregnancy.
Budd-Chiari,
So that was very, very rare.
But Chiari syndrome.
Budd-Chiari is rare. So then we have to take Budd-Chiari's women who were not pregnant and things like that. So it was
Right.
difficult because by itself the female population among cirrhotics is much less than
Right.
So it was quite difficult, but we managed to do it and show the difference in the two groups.
Right. Excellent. So could you tell us why you took 2 controls to 1 case? Just for people. It's coming in my slides, but you go ahead.
Yeah, so sometimes what happens is a patient has certain characteristics. So if you look at only the age of the patient, the gender of the patient was fixed because you were taking only pregnant. So woman, then you take some other characteristic like the grade of the liver disease. So if you compare only a woman who is non-pregnant with liver disease, the grade of the cirrhosis may be different.
Right.
And the outcome will be different. So you have to look at something else. So you have to take a second person whose grade of liver disease was similar. So we have to match them
Okay.
for gender, for grade of liver disease and age.
Right.
So we needed
So
to
3 parameters for matching you had, 3 parameters. Okay. So what are the research question in that, if you recall? What were you trying to find out? Or in other words, what are the title of your publication, please?
So I'll have to check.
No, roughly.
A few years ago, we wanted to know the outcome of pregnancy in women who had Budd-Chiari syndrome versus the outcomes of liver disease.
Okay.
So that was a very different kind of a question.
Right. Okay.
I told
So
I have to look it up.
yeah, no problem. Thank you for
10,
sharing.
15 years ago. So.
Right. Yeah.
So I'll just tell you all this that before we start, that they suggested that we should do a case control.
Yep.
The juniors of the outset, they said we have this data, we can't do a control now.
Yeah.
So we have to go back, pull out the records, the year in which the patient presented. We have to also consider all that and the diagnosis and pull out all the records to get the matching. So it was not a prospective matching.
It's a retrospective matched. And what challenges?
It was done retrospectively. So a lot of challenges in this.
Right. So it was a retrospective. So what was the main challenge you had with the retrospective study?
Because we have to, the matching was retrospective.
That's what. So what are the challenge you had?
So the one is to find the data, many missing values there
Right.
in the patients. So that was one of the things.
Right.
Yeah, lot of
Thank you. That's a good start. So that was while the TV was getting ready. Okay. Thank you for that. But always useful to know what we have here. Now this one is not working. Okay. There's too much technology here. Anyway, doesn't matter. Okay.
We
So
changed everything during the PM thing, and
Yeah.
this was here. I think after that there has been no standardization of the protocol.
okay, folks. So this is what we're going to do. Case control studies. What are the purpose? When to conduct case control study designs? How to select controls? How to select cases? And Madam spoke to us about retrospective design, and then how to analyze and interpret a case control design. The strengths and weaknesses. What are the common biases that we see in case control designs, and we look at some examples. Always good to learn from examples. Okay, so sometimes you wonder, case control design is just nothing great comes out of it, you may think, but let's look at some important discoveries made using case control design. This is history. We rarely go to history. So first, in the 1950s, cigarette smoking and lung cancer. 50s, okay, 75 years ago almost. That was the first report. In the 1970s, diethylstilbestrol and vaginal adenocarcinoma in the daughters. Right, interesting. Let me put this up. Okay, then post diethylstilbestrol and vaginal adenocarcinoma. You can go look it up. 1970s. Okay, postmenopausal estrogen and endometrial cancer. Okay, so 1980s, aspirin and Ray's syndrome. We never give aspirin to children now. Ray's syndrome came from that, right? Tampon use and toxic shock syndrome, right? AIDS and sexual practices, right? So in the 1980s, so 40 years ago, 45 years ago it came. Let's come to the 1990s, vaccine effectiveness, of course, diet and cancer, and more recently in the 2000s, right? I was fortunate to be involved with these studies, the InterHeart study and the InterStroke, where global controversies about risk factors for common conditions like heart attack and stroke. Okay, why do we do a case control study design? And this is a phrase that I like, and I want you all to write it down and remember it. Case control study designs are to determine the strength of association of the risk factors with the disease. Association, case control, association, no causation. Okay, we are doing it at one time, and I'll tell you the difference between association and causation when we do cohort studies. Okay, so I'll skip that part, and then let's go to the definition of a case control design. I didn't want to give you too much epidemiology definitions. Okay, yes.
One question here,
Yeah.
Rudy.
Yeah.
How we differentiate causation and association? Because
Wonderful.
Many
Okay.
times we confuse this. And
Okay.
then they say it is not the cause because you are not sure.
Okay.
Just say association.
Okay, good. Excellent question. I'll answer this. Okay, so now, and let's go to a general thing. Leave out medicine and risk factors and all that. Okay, there were 3 murders in a particular city, 3 or 5 murders in a particular city. Okay, and when they took photographs, at that murder scene, and just when the murder was happening, CCTV camera, they were taking photographs, not CCTV cameras. Okay, they were taking photographs, and every time there was a murder, there was a person with a red t-shirt close by. Okay, every time, every fifth, and the resolution was not clear, but it seems to be the same person. Okay, so will a judge tell this person is the murderer? How many people say this person is the murderer? All 5 times the same person or similar person, same height, weight, color, whatever, but the resolution in the photograph was not so good, you can't make out, and no face recognition technology those days. Okay, so did the person with the red t-shirt cause that murder? How many people say yes? How many of y'all will sit in the Supreme Court and send this person to the gallows?
Association, I think.
Okay, then technology advanced, and then they managed to find out that there was CCTV cameras. Okay, then they found out this red t-shirt person was a different person each time and happened to be there. Okay, the strength of association is quite strong, very strong. Similar red t-shirt, height, weight. It's not male, female red t-shirt. It's not young person, old person. Similar. Strength of association is very strong, but this person, unless you have, okay, I'll step back a little bit. Very important question, so I'm taking 1 more minute to explain this. When they took a CCTV camera, then they figured out it was another person, same person, who would once come sitting on the back of a motorbike, come, shoot that person and disappear. Disappear so fast nobody can take a picture, whatever. And once came in a car once. Okay, then when they caught that person, ballistics, right? You take the bullet, you catch that person, get matched. Who goes to the gallows now? So now the judge has got enough proof to say this person. So there is causation. Now in epidemiology, dear friends, in cross-sectional study and case control design, we can determine strength of association, and it is odds ratio. So for case control also you get odds ratio because it's at one time. In a cohort study, and even better in a randomized control trial, over a period of time, there is temporal association. Temporal means over a period of time. Okay, there is temporal association, and therefore we say that is causation. Madam? Okay, so there must be a time when this was not there, and after some time it was there, and I know both. That is causation. Okay, so I like examples like this from real life thing rather than giving you I can give you an epidemiological definition, association, all that you go read up. Now you got it? This is an aha moment for me many years ago. I was always breaking my head, and my dad used to teach like this. I was telling someone else yesterday, using completely different examples. So now murder, red t-shirt, strong association. It's not once or twice, right? 5 times. All 5 times a similar person was there. It could be the same person. It could be that person's relative who happened to go out to a mall, whatever, together, or for whatever reason. Okay? All right. So let's go now to, yes.
Can you re-explain how you came to the conclusion that temporal association is the causation?
Temporal association. Okay, good. Temporal means over a period of time. Okay? So now there is a point in time when this was not there. Whatever factor we are thinking of is not there. Oh, and after some time it is there, or it is, and then we can say this has caused it. right? When I do cohort study, you will understand it a little better. So we'll do case control now. Okay?
This is something like we do incidence of the disease.
Absolutely. Absolutely. Yeah, that's why incidence you can only do in cohort studies, not in cross-sectional. Okay. Little later they'll get me that warm water. No, later. No hurry now. Maybe during the coffee break I'll take this.
So you want that warm water?
Slowly. Okay. Okay, let's go to the definition of a case control design. It's a method of sampling a population where you identify cases. You must diagnose them clearly. Okay? And then from the population you take controls. It must be the same population that produced the case. That is a control. I can't have a case in Jaipur and take a control from Switzerland. Okay, it doesn't work. Right? It must be the same population that produced the control, but clearly the control does not have the disease. And the same test that we did in the case, we must do in the control to rule out disease. It's not there in my slide, so please write down. In control, you must rule out the disease. Similar diagnostic criteria. And this one, when you come to psychiatry and behavioral studies, you need to use the exact same scale to say they don't have anxiety disorder or depression or psychosis or whatever. Okay? Okay. Then what we do is we measure exposures are determined for individuals in both the groups. Okay. Now when to conduct a case control study design? When the disease has a long latent period, right? Could be liver disease, could be cancers, cardiovascular disease. And when the disease is rare. Why disease is rare? Why case control design is good? Because the disease has occurred. And it's coming to you. They search you and come. You don't have to go searching for them, right? That is why this is good. Okay. Also, when exposure data are expensive. Okay. Now, selecting the cases. You can have population-based cases, preferably to take a random sample. If you take a consecutive sample also, it is fine. Random sample is best. We can take hospital cases. All patients who come to the hospital, every single patient is taken. Okay. Now let's look at the definition and the type and sources of the controls, right? Now we need to confirm, I said this earlier, we need to confirm that the controls don't have the disease, right? Where do we get the controls from? We can get general population controls, we can get hospitalized controls as well. Now when you take hospitalized controls, better to go to another department. Suppose you are doing it in cardiology, right? Go to orthopedics. Okay, or go somewhere else, right, to find that. Okay, this is interesting. Hopefully, okay, anyway, even people who are deceased can be controls, provided you can get adequate data. Provided. In India, that's a bit of a challenge, we don't get data. Okay, so now let's look at the design of a case control study. Now, case control study is going backwards. You have the study population and then we go backwards. We identify the cases, we identify controls, and in the cases we measure exposure, and we, in those who are exposed and not exposed, there will be people there, we do the exact same thing in the controls as well, So now I am going to, madam was asking me this morning, right, teach us little more statistics, I'll do that now, okay. So now I'm going to teach you about odds ratio, I'm going to tell you about 95% confidence interval, okay, and these are critical statistical principles that we as medical people need to know well, okay. So the 2 by 2 table let us take, okay. So this is easy, I'm sure all of you are familiar with this, I'll not explain this too much. Exposed, not exposed. So keep in mind, those who are not exposed also will have become a case. People are exposed, so this is what happens in life. And biology is not engineering. That's important. So I'm sure all of you have studied the anatomy of the human. Start from anatomy. There is no straight line in the human body. There is no right angle, there is no circle in the human body, right? You just try and measure it, there is no perfection. Anyway, so that's what happens in biology. Okay, so now let's analyze the study now. So we have those numbers, and I'll give you an example as well. We'll put numbers also. So the exposed person has two possibilities. One, that person can be a case or a control, right? The odds are A by B. Okay, if you go back, you will recall that it's A by B. There are two possible outcomes for an unexposed person. So, possibility, what are the chances? What are the odds? Sorry, I forgot to put this. So, two possible outcomes for an unexposed person. This person can be a case or not. The odds are C by D. The odds ratio is the odds of a person being exposed becoming a case is A by B divided by the odds of an unexposed person becoming a case C by D. Okay, don't try to mug this up except when you have to do a test in epidemiology, and I don't think anybody is going to. So, you press a button, you will get odds ratio. So, this is where it came from. Don't even bother writing this down. Okay, so if you cross multiply, it is AD by BC. Okay, leave that. Let's go to numbers now. Let's go to numbers, the 2 by 2 table. Okay, so we have now 1000 cases and 1000 controls, right? Of the 1000 people, how many were exposed? No. Got it. 300 exposed and the remaining were not exposed. That's what happens in reality. Exposures are also not very common. Okay. Okay. So this is A, B, C, D. We put that again, and here are the odds of exposure. Don't bother calculating that. And here is the odds ratio. 0.25 divided by 0.11. You get 2.27. Now start bothering. What the hell is 2.27? This is where you are thinking. Your frontal lobe has to come in now. Till then you are in midbrain, okay, right? What is 2.27? This is the output your statistician will give you. Now, one of you, okay, let's assume this is smoking and cancer. One of you please interpret 2.27 for me. Yeah, one of you, yeah, go ahead. Stand up and tell everybody.
More than one, I think there is association between this factor.
Okay, tell us in English, no? Which means leave out technical terms. And so, smoking, yeah, smoking and cancer. You're from oncology, right? Smoking and cancer. Go ahead. Lung cancer, yeah.
There is association between smoking and cancer.
No, I have one 2.27. What do I do with 2.27? One second. Hold on. You'll get your chance. Wait, you'll get your chance. Yeah. Try. There is an association, but we all want to know what is 2.27. What if it is 0.27? What if it is 7.27? Okay, no problem. Please sit down. Yeah, you try.
There is 2.27 times the risk of having the smoking.
Having the smoking?
I mean,
cancer.
compared to non-smokers, smokers have 2.27 times the risk of getting cancer.
Okay, 2.27 risk. Okay, say that again.
Compared to non-smokers.
Right, very good. You have to compare because it's a ratio. Very good. So comparison. So also the first line, okay, which is correct. There is an association. It's more than one. That means there is an association with the exposure and outcome. Correct. You are right. But I want to know more. Yeah.
Compared to non-smokers.
Correct.
Smokers have a 2.27 times the risk of getting cancer.
Okay. Correct. What is 2.27 times? That I don't know. Can you tell me in little more better, simpler language, like how I explained association and causation? Take some other example. Okay, folks, here we go. In the interest of time, okay, so this is how we like to write it. Individuals who smoke had a 127 increased chance of getting cancer compared to those who did not smoke. 2.27, and where did 127 come?
One is
Correct. When do you get 1 in a ratio? So this is what we need to do. When you get 1 in a ratio, when numerator and denominator are the same. So anything more than 1, there is a positive association. Okay, 1.01 also is a association. Okay. Now, are you happy with this? Now, will you ban smoking? Based on this, what do I need to know? So, is this statistically significant? Okay, friends, what is the meaning of statistical significance? Okay, in very simple terms, let me tell you. Okay, in very simple terms, statistical significance means the result that we have got is real. Although it is biology, it is real. Okay, and it's not due to chance. It's not just like that it happened. That means, okay, and what does a 95% confidence interval? I'm coming to that now. What does that mean? If I do this test 100 times, 95 times, I will get an odds ratio of 2.27, which is between this confidence intervals. Okay, and if you want to look at it in terms of probability, right, there is a less than 5% chance that this is spurious or whatever. So that means more than 95% I am sure. And we human beings, of course, there is a criticism for p-values now. We'll go to that later. That is advanced. Okay, people are criticizing the p-values and saying whatever. But for now, simple understanding, if I'm 95% sure, I'm okay. Okay, friends? Okay, so let's move on and let me tell you how we compute the 95% confidence interval. Okay, so is this odds ratio of 2.27 statistically significant? I want to know, right? So we are going to compute the confidence interval. So go back to the same numbers. You have the odds ratio of 2.27, and for those of you interested, this is how we compute the standard error. It is the square root of the sum of the reciprocals of each of those. Don't even bother remembering that. Okay, that's not headache, no need. Okay, and the formula for the 95% confidence interval for an odds ratio is the exponential of the log odds ratio plus or minus 1.96 into the standard error. 1.96 is for 95% confidence interval. All right, so we do this, and when we put these numbers together, you get two numbers. Ta-da, you get two numbers, 1.24 and 3.80. What does it mean? If I do a similar case control study, right, similar patients, right, 95% of the time I will get an odds ratio which lies between 1.24 and 3.8. Once I will get an odds ratio which is 1.34, another time I will get it 3.13, another time I will get 2.63. Got it? 95 times I will get it within that. Only 5 times it will go outside of this. I am happy. Okay? And another thing for all of us to look at is how narrow is the confidence interval. Larger the sample size, more the outcomes, right? Narrower is the confidence interval. That means your estimate is precise. Your estimate is precise. So that's what we need for. Okay, now how will, so your statistician will give you so much. They'll give you a printout, but rest of the writing is your job. How will you write this? So you write it like this: OR 2.27, comma, OR 2.27, 95% CI is 1.24, comma, 2.89. Okay, you can't see that there. Oh dear. Oh, right.
That I believe is a huge kind of variation in the confidence interval. So does it make the interpretation, how do you interpret this?
How do you interpret that?
So is it more than 1.27 and
I'll tell you.
value is fine with us? Or?
I'll tell you. Let me show you the numbers. It will make more sense that time. So Dr. Mohit's question is, how do you interpret a confidence interval? So firstly, what does it mean? That I think everybody is clear. Is everybody comfortable? What does a confidence interval mean? Okay, what are those two numbers? What it means? Okay, and without a p-value, can we? Okay, now let's go back to this. Okay, so where are we now? Okay, so we got this odds ratio of 2.27, and I told you how to calculate the standard error and the 95% confidence interval. Those are all the formula. Okay, and if you compute that, you will get 1.24 and 3.89. Okay, how to write this? This is how, and you will, all standard journals will write it like this. Okay, 2.27, right? 95% CI, that is confidence interval, 1.24, comma 3.89. So you must write 95% CI each time. Okay, otherwise we don't know whether it is, and you don't do 90%, you usually do 95, 99% of the time you do 95%, very rarely 99% you do. It depends on your question. So firstly, is this statistically significant? Let's sort that out. Now all of us are comfortable that what does 1.24 and 3.89 mean? That means if you do this 100 times, our odds ratio will fall between this. It can be 1.24, 1.25, Okay, it can be 3.88, 3.89, it can be 2.26, right? It can be anything, but within this, it will be within this. Okay, so that's what it means. Now, next one is it statistically significant? Do you want a p-value for that, or are you comfortable? Is it statistically significant? How many people say yes? Okay, so there are hand must be up like this for me to count. Okay, 1, 2, 3, 4, 5, 6, 7. Okay, how many people say no? How many people say IDK? Okay, IDK, good, very good. Okay, so very simple, dear friends. In a ratio, the determinant of significance or not is 1. 1 means numerator and denominator is exactly the same, not even fifth decimal point, is exactly the same, right? Okay, so therefore, if your confidence interval crosses the line of no effect or the point of no effect, which is 1, if it crosses, it is not statistically significant. That means we are messing up with things. Just pour half, please. You got it? So if this confidence interval was 0.84 and 3.89 and odds ratio is 2.27, it's possible to get that. It is not significant. Got it? It can go the other way around. When I do hazard ratio, I'll tell you, you can get an odds ratio of 0.64. Okay, and for 0.64, the 95% confidence interval will look something like 0.24 to 0.89. That is statistically significant. It is not crossed 1. Same if you get 0.34 to 1.64, it is not statistically significant. Okay, you don't need a p-value for that, right? Now the next thing, Dr. Mohit, your question is a little tricky. How do I know whether it is narrow or not? It comes with experience. You need to see lots and lots and lots of confidence intervals, and then you will say, okay, this is fairly narrow, right? Suppose the same thing, 2.27 was 1.01 and 9.43. What would you say?
1.01
and 9.43. Odds ratio is 2.27. Exactly. You got it. So it comes over a thing. Okay. Now
even then it is significant or not significant?
It is significant, but it's not a precise. So you will get an odds ratio and a confidence interval for that when your sample size is very small.
Small, yes.
Okay.
So you have to have a bigger sample size.
Absolutely. Okay. I'm going to skip the next part.
Sir, can I add one question here?
1 second, please. Let me just see. Okay, let's do this. Yes, question. Go ahead.
Sometimes when we are preparing these protocols or synopsis, the statistician reduces the confidence interval from 95% to 80%, and then changes everything. Means all the data, all the power of the study, everything changes. So is that okay, or is it not?
No, your statistician will change the power of the study, not the confidence interval. Okay. Now, power of a study minimum is 80%. Okay. Anything below that is not worthwhile doing, because the error, the type 2 error you are ready to accept is a 20% error. Okay. Anything below that, that means the error rate goes up more than that. That means your study is not good enough. Okay. Statisticians will do that. So when you lower the power, your sample size becomes lower. Right? Okay, so shall we go to case control and we'll conclude this with an example. So it will give you the applications and then we'll move on. Okay, you're comfortable? You're still looking anxious? You're all right? You still look? No, I blanked it out. We'll do one thing at a time. We'll answer this question because people are reading that otherwise. Yes?
So like in this example, it doesn't mean that like it is not statistically significant.
Somebody else answer this question for him.
Because what we understood was like if it is within the 95% confidence interval, it is like it will be the p-value will be less than 5%.
Where is p-value? I didn't discuss p-value so far. Is this significant or not? Can one of you convince him?
Sir, if it lies between 1.24 and 3.89,
anything more than 1 is significant.
No, no. He's got a very simple question. Is this significant or not?
It is significant. And the reason it is significant is that the chance of association between the disease and the disease is more often occurring because of the exposure. So you have a 1.24 which is more than 1. So the chance of having a disease with the exposure is more than without the exposure or with the control. So it has to cross 1 on either side. So it was, we talked about hazard ratio of 0.64. So you had 0.2 to 0.8 is your confidence interval. It is less than 1. That means whatever it was protective.
Okay, absolutely. So in a simple way to answer your question, doctor, is both, okay, I didn't use the word previously, both bounds of the confidence interval, those two numbers are called the boundaries of the confidence interval. They are called boundaries, okay. Both the bounds or the boundaries did not cross the line of no effect. For a ratio it is 1. Okay, so it is not crossed 1. Okay, if this was 0.99 and 3.89, possible, not significant. 0.99. 1 is significant, 1.0, 1 and above. Okay?
0.01 in the example that you gave.
Yeah.
You have to think about it very carefully.
Exactly.
Once the confidence interval was up to 9, so 1.01 I would get a little suspicious.
It is significant. For that study it is significant. Will I apply it in my population is a big question mark, not a small one. One is it's wide, then it is just about 1.01. Got it? So what I would like is if this one was 2.3 and 2.94, so sorry, 2.03 and 2.84 confidence interval rather than 1.24 and 3.89. That means you have 10 times the sample size here to get such a tight confidence interval. Did you get that? And I think some of you were discussing the tightness. Okay, shall we move on?
Yes.
Okay, lots more to do. I'm skipping population attributable risk, but I want to tell you strengths of case control designs. Okay, it's good for rare diseases. These diseases reach you. Liver disease, your blood sugar, you did that, right? They have a long incubation period. Okay, and very important is the second point there. Okay, many risk factors for the same disease can be determined. I gave an example of cancer and smoking, but you can look at multiple things: cancer, diet, consanguinity, to exposure to heavy metals, to climate change, to which political party you belong to, and all kinds of things you can do. It's a risk factor, no, belonging to a political party also. Okay, right? And it's good early days, right? Early days of a disease, Kaposi sarcoma, catch them all, okay, and people without, what are your sexual practices? Oh, okay, right? So that's how they figured out HIV AIDS in the late 70s and early 80s, okay. Weaknesses though, okay, inefficient for rare exposures, okay, because you need huge sample sizes for that, okay. Lots of biases are there, and this study is of a retrospective nature. Madam's study is a retrospective case control design. This retrospective means cases and controls are gone in the sense they are not there. Okay, we are taking the case records and going backwards. Okay, the challenge with that, it's easy to do, but the big challenge with that, even in the best of centers in the world, is inadequate data. Okay, and particularly in Indian settings, inadequate data, patients take away the data, data are lost, all kinds of things happen. Okay, so the big problem is recall bias, and I told you this as we were starting off when Madam asked the question about association and causation. We cannot infer temporal relationship between exposure and disease. Which came first, we don't know. Person could have had cancer, okay, it's not yet manifest, and the person is not feeling okay and maybe restarted smoking or started smoking at that time. We don't know which one came first, right? But in a cohort study you can do that. Which one came first, exposure and outcome, you'll be very clear about it. Okay.
So they are not always retrospective, they are always, there are many prospective studies also.
More than 90% are prospective studies. Retrospective is possible, is not good enough.
Yeah.
Is not good enough is what I'm saying. Yeah. Okay, let's look at biases in case control designs. One is selection bias. Many patients with cancer will say, I don't want any studies. My cancer and my thing is hard enough. Okay. Then detection bias. Some you may not be able to detect. Okay, more important than that is the observation bias. This is called recall bias. I'm going to blank this and I'll explain recall bias for you, because that is something you have to deal with. The statistician can do nothing about it. Let's take a scenario. In the CCU, patient has had a myocardial infarction, okay, and you are asking him exposure about smoking. Let's say patient is 65 years old. Okay, you are asking exposure of smoking, 65 years old, but the patient will recall when he had his first cigarette, 15th birthday. My 15th birthday, my friends bought one packet. Parents were having party, cake was getting ready. We went at the back. I had my first cigarette that time. Second cigarette, my friend's birthday next month. Same date, my best friend. We are still friends. You follow, Sala, he's not got cancer. He's not got thing. He'll tell you. How many years is this? 50 years later. 50 years later, he recalls very clearly. When he had the second, he'll tell you the brand name of the cigarette. He may tell you the name of the matchbox that they used. No lighters those days, no, we used matchbox. This is this kind of matchbox. And then he'll tell you, okay, by the time I was 20, I was smoking every day. Okay, 20 to 30, every day 2 packs. 30, I got married. Then my wife, whatever. Then I reduced a little bit. Then family tension, 32, 30. Within 2-3 years of marriage, I started again. More than that. But he'll give you details. And then he will tell, I began to get chest pain. I stopped for 3 weeks when I was 40 years old. Then look at the detail he'll give you. Then you go to control. Same 65-year-old male control, no heart attack. Sir, did you smoke in your past? Smoking, yeah. I mean, childhood sometimes I smoked. And when did you start? Maybe in my teens. Or I think I was about 28, 18, something like that. That's the first time I smoked. And then 1 or 2 sometimes, when we go out, tension. And then in my 30s, I kind of smoked. And then for many years I left. How many years you left? Maybe 2 years or 2, 6, 8, about 10 years I left smoke. No, maybe something like that. What will you write? You are waiting to give a number. This is recall bias. This is recall bias. Quite likely this person is smoked exactly like that person, but is giving you very different data. You don't know what to write. Okay. Now, why is the person with a heart attack able to remember all this? From the time he is lying in bed, a whole world told me to stop smoking. See now here, angioplasty with stent, 2.5 lakhs already down, and my wife, I don't know how to face her now. Every detail. So this is recall bias. For all exposures, you will get it like this. So what you have to do? You have to spend more time with the control. That's all. Now that you understood recall bias, you have to spend more time with the control. And then come back later and ask them about smoking again. Please try and recall. Could you give us little more data later? Because collecting, and I told you earlier, one of the weaknesses is not being able to measure the exposure well enough because it's retrospective. Prospective, when you do a cohort study, is very easy. Every month you can collect data. You will get accurate data. Okay. All right. So I'm going to, in the interest of time, skip this nested case control design and give you advantages, disadvantages, one example and we'll close. Okay. Rare diseases, new diseases, outbreak investigation, induction period is long, multiple exposures, relatively inexpensive. Look at this list, it's beautiful. So my message for you, dear friends, is this is a very efficient, did I use the word efficient here? No, it's a very efficient design. Unfortunately, not many of us do good case control designs. What people do, I'll tell you, and this is a mistake. But these studies are, you will tell, what Dr. Dennis, you are telling mistake, but this is published in this journal and such a big shot has published it. Mistake is a mistake, right? It's not good enough. Where you collect cases and then 6 months later you'll say, hey, kuch control hai na, kahin se bhi. Some control without the disease, they'll put it together and you'll, sometimes you'll say a comparative study, you'll say. It's not a design. A comparative study is not a design, now you know. But these are published. A comparative design, and then and they'll call it all kinds of things, is not good enough. Okay, let's also be aware of the disadvantages. Okay, now you are selecting cases and controls. They are susceptible to exposure misclassification, particularly recall bias. I spent a lot of time explaining recall bias because you have to fix this. Nobody else can help you with that. So if you are getting your junior to go and collect data, explain to them recall bias. Arey Baba, spend enough time. Don't get irritated with the control. This is a problem. This is reality. Okay. So this morning also we discussed what is a bias. It gives you wrong. It's a systematic error. Okay. We can minimize it. You cannot completely avoid it. You can minimize as much as possible. Okay. And in a case control design, we are looking at a single outcome. Cancer, MI, liver disease, etc., etc. In a cohort, multiple exposures, multiple outcomes. Okay. you can do that, and you can tease it out. When we come there, I'll tell you about confounders. Okay, obviously you can't calculate incidence rates, and you cannot assess. Okay, let me give an example and we'll close. Okay, and this is a study that we did, published in the Lancet. This was my Hope Scholarship project proposal that I wrote to the Canadian government in 2004, and I got the scholarship in 2005. We did this. So Martin and I led this study of strokes in 22 countries. So Martin is a friend, he's in Ireland right now. So both of us, and there are a bunch of other people who also did the study with us. Okay, so this is in two parts. This is the first part in 22 countries. These were the different regions: high income countries, South America, China, India, Africa. We had 2000 ischemic strokes and about 520 intracerebral hemorrhage and 35 subarachnoid hemorrhages, and then they were broken up here like this. These were the 2400. This is the breakup. Okay, now this is a busy table, but in this itself you can look at the age difference. Now overall age is 61, high income countries 66, in India it is 58, in Africa it is 57. Big difference between 66 and 57. So people in India and Africa are much younger. That itself you have to sit up and say, oh, what's happening? Okay, so and the proportion of people who are less than 45, only 8% in high income countries, 25% in Africa, less than 40 with strokes. Okay, so that itself gives you public health messages. Okay, now let me tell you how to compute the odds ratios, or you know what, I'll go to the next study, the next publication. So we expanded this to 10 more countries. It went to 32 countries. This was published in Lancet in 2016, and we had totally 26,919 participants. Now one of you, when it comes to publication ethics, you can ask, why did you publish only 2000 and then you went for 26,000? These results were so compelling with 4,000 patients itself. Main Lancet paper itself accepted it. Said no, it's important and it's a global study. Let's get the preliminary results out, and including those results we added to these 32 countries, and so the sample size here is 26,919 from 32 countries. Okay, let me show you. Now this is again age, etc. I'll skip that and I'll show you how we put multiple risk factors and show the odds ratio. Okay, now hypertension, self-reported history of hypertension. This dot in the middle is the odds ratio, and then the little line on either side, can you see? Here you can see those lines. Okay, here you cannot see because, and this line on either side is the 99% confidence interval. Can you see here? 99% confidence interval. We were so confident because we had such a large sample. And can you see how narrow the confidence interval? Dr. Mohit, you wanted to see narrow confidence intervals. Here you go. Odds ratio is 2.56. 99% confidence interval is 2.3 to 2.8. So what does 2.56 mean for hypertension? Those who have hypertension have a 156% increased chance of getting a stroke. Don't stop there. Compared to those who don't have hypertension, because we are compared to them. All right, that's important. So let us go, let us say to, this is, what else you want to see? Current smoking, let's take smoking, right? Smoking odds ratio is 1.67. Let us take physical activity. Look at this now, physical activity, regular physical activity, odds ratio is 0.60. Look at this, 0.52 to 0.70. Somebody interpret 0.6 for me. Regular physical activity, 0.6.
The person who is doing physical activity has a 40% less risk of getting a stroke as compared to those who don't do physical activity.
Excellent. Give him a round of applause, please, everybody. Okay. Okay, one of you repeat this from this side. One of you, come on. Just repeat what he said in your words. Physical activity, 0.60.
40% less chances of having stroke compared to a person who do not have exposure with a physical activity.
Who does not have regular physical activity. So, in other words, if you have regular physical activity, you have a 40% statistically significant, and that's real. That 40% is real. Okay, and another thing to look at is, look at how far 0.7 is from 1. Okay, see how far this is. See, this is so far away. So this is 1. Can you see 1 here? This is how to look at a forest plot. Okay, 1 is here. This is the line. So diet and good diet and physical activity are protective. Whatever is this side is protective. Whatever is other side is harmful. Okay, right. So yeah, we separated out ischemic stroke and intracerebral hemorrhage, and let us skip that part. So summary, case control designs is robust. It's a strong design. It's a robust design to determine the strength of association of risk factors with the disease. So friends, I love this phrase and I want you all to remember it. Okay, strength of association. Bigger the odds ratio, smaller the odds ratio, far away from 1 is strong. Okay, so strength of association of risk factor with a disease. Okay, cohorts and RCTs are better designs to determine causation. Case control designs are ideal when disease is rare, long latent period, and in the methodology you have to sample cases and controls and measure the exposure retrospectively. And what is our measure of association for a case control study? Odds ratio. And how do you know whether it is significant or not? The 95% or 99% confidence interval or a p-value. Okay, and always go for a 95% confidence interval. Okay, all right. 2 questions let us take in the interest of time.
Just quickly, one question I will ask. You said CC is ideal for diseases which are rare.
Yeah.
So that means diseases which are common, say for example tuberculosis, there we can't do case control studies.
Why bother with the case control design when there is, well, you know, actually, how common is TB? Now, what is the meaning of common? Right?
What is
so what is our population prevalence of tuberculosis now?
I can't say exactly as of now.
Is it 5%? I don't work in tuberculosis. I don't know. 5%, 10%, 15%?
Must be, no, less than 5%. It has to be 0.05%.
It is still rare, madam.
Achha, so from that angle it is rare.
So there.
Because when you say rare, that becomes a separate, altogether rare diseases comes in our mind. Malaria, tuberculosis, these are very common.
So now when you have, let's say 1%, that means every average patient who walks into our hospital, 1% has. Okay, so if you have 1,000 patients, so possibly 10 patients have tuberculosis, and if you wait 10 days, you have 100 patients. Right? When you talk about rare diseases, you see them once in 6 months. So even then, if you see them once in 6 months, and if your sample size is 400, you need to do a multi-center study, recruit over 1 year. Okay, one more question in terms of methodology of case control designs. Methodology. Okay, I'm going to shoot out questions now for y'all, just to revise this quickly. Right? So where do you get controls from? Oh, by the way, I need to tell you something. You know what is the big problem with case control designs? Big problem. 2 big problems. Number 1 is finding controls and getting them to consent. Okay? We are doing a study on cancer. We want to collect data from you. We want to do your measurements and we want blood test, and by the time you complete, patient will run away. Patient will think, even if I don't have cancer, if I give my blood to them, they will give me cancer. So when I do the session on ethics and patient recruitment, this is what I tell people. Very briefly, I'll tell you. The only reason, listen very carefully, the only reason a patient should participate in research is to advance science. Patient participates. You don't subject the patient to your study. And so therefore, it is our job to explain the study to them. You say, he is illiterate. 70-year-old coming from interior village, what am I going to tell him about risk factors? Biomarkers, novel biomarkers. In their language, it is our job to tell them. We have to go to their level, and it's not easy. That is why research becomes difficult. One of you were telling, what are the challenges with research? Patients don't cooperate. Somebody from here told yesterday. Because we take them for granted. Right? And the other extreme is also wrong, which is, Doctor Sahab, aap kuch bhi kar lijiye. नहीं कुछ भी कर लीजिए आगे हम आई एम हियर कुछ भी कर लीजिए आप तो भगवान है no that is also no I may be Bhagwan whatever okay but you have to listen, you have to understand, you are helping patients like you in the future. Make them not in a false way, making them feel important. They are important. Today, if we didn't have patients, we don't have all these treatments, we don't have all these understanding, right? Right? Yeah. Yeah, please.
So, how do you select number of controls?
Oh, excellent question. Okay, two things I'll tell you, number of controls and factors for matching. It was not on my slides, I'll tell you both, very important questions. Okay, usually I do this session over half a day. Okay, so this is an abbreviated version, but these are important points which I will tell you. Okay, number one, okay, it is enough to have a 1:1 matching, enough, provided you have an adequate sample size. If the disease is very rare, okay, you can take 1:2 controls, 2 controls to every case. That's what you did in your study. Because the disease is very rare, you increase the power of the study because your overall sample is increased. Okay, epidemiologists say, and I kind of believe it, that more than 1:3 is useless. It doesn't give you your odds ratio, it doesn't enhance the value. They have done different modeling. More than 1:3 is of no use. People have done 1:5, etc. because the disease is so rare, they want 5 controls, overall sample size looks good, it's of no use. So the other 4 and 5 control that you got in has not added value, and this is unethical. In fact, my session on sample size, we speak about ethics first. Okay, maybe madam will do that whole session on sample size, maybe just after this. I'll finish this part. Okay, which is number of controls for a case. Can you flip that over? Can you have more cases and controls? Yes, for the same reason, to increase power. Okay, you can do that. Same thing, so you have lots of cases, and the procedures are so complicated, your controls are not going to come. Okay, so you need long testing, and then people have to stay for some EEG measurements. That's all crazy, right? So EEG measurements, and then so many scales to take. We'll pay you. No. Why do I have to stay in hospital the whole day or come back for follow-up and all that? Okay, so more than 3 is not worth it. Okay, next is matching. I remember I told you yesterday.
No, how minimum we can take control? Supposing
1:1.
No, that is okay. But you said we can have more cases and less of controls also.
Same
if it
thing.
Is difficult.
Same thing. 3:1. Less than 3:1. So in other words, you can have 3 controls to 1 case or 3 cases to 1 control.
Okay.
More than that, either way is of no added value.
3:1.
Correct. Okay. Now factors for matching. Usually only 2 factors: age and sex. Okay. I will take you back. I always like to tell a little story. I remember this in 2005 on a very cold day in McMaster University. It gets very cold. It goes to -25, -30 centigrade. Anyway, so we were doing that, and I was very excited with this matching and how we do all of this. So in McMaster, it's all small group teaching. So 6 and 7 people sit together. We read papers and we discuss. One tutor will be there, and then so I spoke, and whenever I make mistakes, I happily tell you people. Okay. And I said, no, we need to match for this, so that we eliminate the effect of all that, and therefore we get a very nice thing. I explained. So the tutor listened very, very patiently, and then he told me on that very cold day, I remember that very clearly, matching beyond 2 doesn't add value, doesn't add great value. Rarely you have a third one, and I agree with you, madam, in that design. One is a smaller sample size. Okay, you match for severity. But no, you can't match for severity of disease because other person doesn't have a disease.
No,
so
one didn't have the disease and one had severity of the disease. You have to match that.
Okay, no, that is stratified sampling. Probably. No. Yours was stratified sampling. It's not the stratified means you ensure that you get different because you can't match for severity of disease. Okay, that's the third. Maybe a third parameter you can possibly socioeconomic status they match for. A poor person with a poor person. So maybe the third one. So beyond that, don't match is what they say. Okay, right. Any other questions?
So you said that we should always take controls from hospital. But in one of the study, we did case control.
I didn't say that. Sources of controls can be population or community and hospital.
But you said other departments.
In the hospital itself, don't take from the same department. Okay, cardiology to cardiology.
So that's what I want to share. So we did Guillain-Barré syndrome,
right,
association with Campylobacter, and we took GBS cases from neurology department, and we took non-GBS cases
Right.
from neurology department.
Right.
And the third, we took relatives, or what you call brothers, sisters of the patient. That was our third control. So
hold on. There itself. In my humble opinion, taking relatives as a control is wrong.
Okay.
Is wrong. Okay, if I reviewed that paper, I wouldn't accept it.
Okay.
Or
So
if
what is wrong with that?
because of the genetic association.
So that's exactly what we wanted to show.
You need a different design for that, madam.
So what I want to
Okay.
tell you is that Campylobacter is occurring because of eating food and water. So wanted to check whether the same exposure is there in those controls.
In siblings,
and whether they in the siblings.
Right.
So whether they could get or not
So-
associated with GBS. That was our purpose.
Right. No. So in terms of principle, this is the challenge with genetics, and therefore, I'm giving you textbook. There we go again. Okay, I'm giving you textbook classic situations, but there are other places where you have to make these adjustments and carry on. Okay. So why don't we all stand up for a few seconds? Stand up. We've been sitting the whole morning. Oh, this mic is much better than that, isn't it? Yeah. Okay. So while the TV is warming up, let us also warm up. Okay. So push your chairs behind. And make sure you have elbow room. That means you're not going to, push your chair behind. And yesterday was push your chair forward. Now this is push your chair backwards. Instructions have to be very clear. Okay, so you can do this for your workshops, seminars, whatever. Every couple of hours you need to stand up and do. Yesterday we did high five, whatever, and moved around. Okay, so today what we're going to do is a little bit of exercise. And it only takes us, let me increase volume here probably. No, volume. Okay, it only takes us a minute to actually do this, but since I'm demonstrating for y'all, it will take a little longer. Okay, make a tight fist like this. Okay, fist and release it. Fist, release, fist, release, fist, release. Okay, good. That already feels good, isn't it? Okay, then, enjoy. Yeah, that's the important thing. Okay, then to your shoulder and back. Shoulder and back. So in other words, flex your elbow and back. So do this now. Tight fist, release. Tight fist, release. Tight fist, release. Okay. Gentle fist on your shoulder. Gentle fist on your shoulder. And now gently rotate your shoulder. Okay. Because you're sitting in a cold room. Gently rotate your shoulder. Okay. Feels good, no? Okay. Feels good. Okay. Hands on your hip now. Just loosen up your shoulder, hands on your hip without moving your hip. That means you shouldn't do this. Hip must be stationary and move to one side gently. We don't want people with back aches now. Okay, gently. Feels good? Feels good. Okay. Now your entire hip as well. Turn your hip to the left and to the right, to the left and to the right. Okay, all right. Okay, now we have to rotate our ankle now. Okay, so you have to rotate your ankle this way. Okay, not your hand. All the time it happens. Okay, because I can't show you. Okay, so hands on a hip again. Lift your leg a little bit and rotate. Lift your leg and rotate. You can hold on to the table if you want. Okay, lift other leg and rotate. Lift other leg and rotate. Okay, and then stretch your hip a little bit. So any physiotherapy people here, any joint or any muscle we left out?
The neck.
Any? Neck. You know, I learned a few years ago, we're not supposed to rotate our neck. You know that? Yeah, so don't, I mean, you see people warming up. Okay, maybe young people can do that. Okay, so maybe neck, try to touch your chest with your chin. And back and front. Back. Okay, now the best part. Okay, you still go. The best part is just loosen up, shake, right, left. Okay, now start clapping and turn to your right. Turn. And the other way around. Okay, please sit down comfortably. We are going to take a bio break shortly. Yeah. We're going to take a bio break shortly. Okay, sit comfortably. Preferably your hands on your thighs. Okay, and glasses out. Okay, I'm going to have my glasses on for something else. Can we dim the lights?
Yes.
Okay, sit comfortably. Just 5 minutes. One of you dim the lights, please. Okay. Gently close your eyes. As much as possible, back should be straight, neck also straight. Yeah, but not stiff. Gentle, relax. You must be relaxed totally. Just enjoy the silence for a while. Just enjoy the silence. Just observe yourself where you are. Now, observe your breathing now. You're breathing very gently. There's no difficulty in the breathing. And observe that in your nostril, when the air is going in, it is cool. And when the air is going out, when you exhale, it is warm. Just observe that for a few cycles. What you inhale is cool air, what you exhale is warm. And in this state, let us be grateful. Let us be thankful. Think of a person who you want to share your gratitude with. Who do you want to say thank you to today? One person. Now think of something that you want to be grateful for. Your education, or the country we live in, or the family members we have. What do we want to be grateful for? Or the good health that we have now. We're able to walk and talk and come. For a couple of minutes, let's listen to this music. Okay, take your time now and gently open your eyes. There is no urgency. If you want to keep it closed for some more seconds, you can do that. Gently open your eyes. If you want, you can gently rub your eyes. If you want, if you feel like, gently open your eyes and be in that state now for some more time. You're back to this boardroom. We're going to continue another day of learning. Gently open your eyes. Okay, just as an experiment for ourselves, those of us who want to go to the washroom, we just go out without making a sound. Quietly just go out without making a sound, and we come back. Tea is going to be served and we will return to our session in 10. So let's do randomized controlled trials, and this is what we will look at. We look at what the definition is, and we'll go back to the research question. We'll go back to the research question. I'll give you a template to write a research question and the components. We look at what different types of interventions can be done. Many times we think it's only drug, right? Yes, it's the commonest one. There are so many other interventions, and very importantly, the next section, which is the different concepts. What is randomization? What is allocation concealment? What is blinding? And what are outcomes or endpoints? So for my master's thesis, I was asked this question: difference between allocation concealment and blinding. And this is into many years ago, 15 years ago. I'll be honest, I didn't do a great job. But since I did not do a great job, it is now so clear in my mind. After this, I have taught this many times. Okay, then we look at analysis and interpretation of trials. We look at quality of trials, and we look at examples. Then we will also do part 2, right?
You want this tea also? You can leave one here. This may not be that sweet. What you
yeah. The first few, which is a definition. So, as we said, this is an interventional study. That means we are doing something where investigators or researchers prospectively assign people. Prospectively, you are telling you get this to one of several interventions. It need not be only clinical interventions, it can be anything. Okay, but the critical thing is, how do you say you go to this group and you go to that group? It's using the phenomenon of randomness. Using the phenomenon of randomness, and I will tell you a little later what that means. Let's first go to the research question. Okay, first one is your population or patient, then the intervention, then the comparison, the outcome, the time period. Okay, and one more thing we can add here, the study design. So using a cluster randomized trial, a non-inferiority design, a factorial design. So you could say all that. Okay, so here is a template for a research question. Okay, among patients with a particular condition, this is our patient, does intervention A, that's your intervention, compared to standard therapy, intervention B or placebo, that is your comparator or control. Okay, reduce complications or death or whatever, or reduce blood pressure, reduce biomarker, whatever the outcome may be, over a period of, this is very important to say, how long did you give the intervention? How long did you give the intervention? Time duration. Okay, and then you can add the study design also. Okay, quickly, rapid fire types of interventions. So drug, we know. Medical procedures. We can do surgical versus medical procedures. We can do health systems intervention. We can do complex interventions. Complex does not mean complicated. So I'll tell you, right, the difference. Drug therapy example, you know that. Medical procedures. Okay, we actually did a trial looking at radial versus femoral artery access for primary PCI. Any cardiologists here? This group, cardio people here? No? They are doing interventions, I think. No? Okay. So we did this study. Okay. Maybe in psychiatry, you can do ECT versus medical therapy. So you can compare different medical procedures. Okay. Then you can compare Okay, lifestyle versus medical therapy in diabetes. Intensive lifestyle versus no treatment or versus metformin.
Yoga.
People are, yoga of course. Okay, we can do all of that, that's part. Okay, surgical versus medical. Bypass surgery versus primary PCI in ST elevation MI, we can do that. Health systems interventions. Can health workers help to improve medication adherence after an acute coronary syndrome? We did the study and then we published it in the Lancet. I will show that to you. Complex interventions. Here we go. Example of complex intervention. Complex intervention simply means more than one type of intervention in the intervention package. So it's an intervention package that you're giving, and this is important. So look at this: behavioral therapy, mobile reminders, and home visits for people with tuberculosis, for people with HIV, for people with high risk cardiovascular disease. Right? So we can do all of this. So this is a package. Okay. Here is an example of a study that we did. I led this study. Community health worker based intervention for improving adherence or for adherence to drugs and lifestyle after acute coronary syndrome. It was a randomized controlled trial, and we had 14 hospitals and 804 patients, and we did this. Okay, so this study I led, and we did this around the country, and Dr. Rajiv Gupta from Jaipur, he and I worked closely on this, and that's why he's the second author of this paper. Another study that I was involved in is radial artery access versus femoral artery access for a PCI. So we did this study many years ago, and we found no difference between radial and femoral artery access. And so whatever you're comfortable with, you can do. We're not saying one is better than the other. Okay. All right. So the C in RCT is control. Why do we need that control, right? And how and why is it important to set us up? So this improves the internal validity of the study. Internal validity means, right, you're testing your intervention really well and you're getting a good result within the trial. What is external validity? Very good. Generalize it to the population. So for that, what do you need? You need proper sampling, you need adequate power, and you need to get a statistically significant result, which means, what do you mean by a significant result? It means I can apply it to the population with confidence. Right? You need not say only for these patients. Okay. So it's a meaningful comparison that we do. And what can I take as a control? This is a big question. We debate this a lot. Your control depends on standard of care at that time. There have been several trials. I keep going back to cardiology because that's where I'm comfortable with. There were so many trials, maybe a couple of 100 trials that did thrombolytic versus placebo. Can I do that now? Today, can you design a thrombolytic versus placebo? Why not?
Because thrombolysis is standard of care.
Thrombolysis is standard of care. So what trials do we do now in acute MI? Over and above thrombolysis, what can we do? Okay, we can't do versus placebo. Okay,
So just a question.
please.
Maybe you can think over it and give me an answer later. A lot of studies, their standard of care is established. US FDA still insists that they want a placebo arm.
That they want a placebo arm. So in the early 2000s, there was this big controversy. There were literally 30-50 letters going to NEJM. At that time, in the early 2000s, standard of care for HIV was established. HIV was established. American researchers went to Africa and did HIV drug versus placebo. It became a big global ethical issue. Okay, a lot of controversy. Okay, I'll give you both sides of the story. You decide whether it's ethical or not, and we'll not discuss this further. Let's go back to RCT. Okay, so the question the researchers tried to ask, and many people agreed with this. This is the contentious issue which you all can debate. So they said, in an African setting, HIV drugs, which are so expensive at the time, and thanks to Indian pharma, that changed. It was so expensive, $30,000 a month. A year I think it was. Sorry, so not a month, per year. So $30,000 is how much now? $10,000 is 8 lakh rupees. So 24 lakh rupees, 2 lakh rupees a month was treated. You can't afford it then. Does this work in Africa? We've never tested HIV drugs in Africa. So that was the argument for a placebo-controlled trial. They did it and published it in the NEJM. Then all this trouble started. Okay, so Please look at the third bullet point. Depends on the standard of care at that time in that place for sub-Saharan African countries. Okay, so let's move on. Okay, types of controls. We'll discuss the next matter over lunch, madam. Okay, right. Types of control. Placebo we use when there is no effective treatment for that condition. Okay, and so I told you 70s, 80s, even early 90s, thrombolytic versus placebo was done. Okay, and if not, you need to use an active comparator, and that is the best available drug at the time recommended by guidelines. Which drug do you use? Best available drug. Okay, applicable to that population. Best available need not be the most expensive, the latest one. So keep those things in mind. We spend a lot of time discussing what control to use.
Excuse me.
Yes.
If in practice, if there is any treatment modality which was like obsolete before, but we want to try it in a new setting, then like can we do it?
Yes. So before I tell you another yes, give me an example.
For example, I'm coming from blood transfusion. So previously it was like only whole blood. That time there was no blood components was like it was discovered. So whole blood was the norm. But now almost like everywhere in it is 100% components. Yeah. But in certain
you need to give
specific patient population, there are like some studies that like whole blood works better.
Yeah, correct. So a treatment that was used in the past not being used anymore, can we try it out again? Yes, and this is called repurposing drugs or treatments. You can do it and you must do it. And who will do it? Academics have to do it. Pharma companies are not interested in this. There's no profit in it. Okay, so please keep this in mind. Very good question. Concept for all of you. Look at repurposing drugs that are already there for two reasons. One is it's cheap. Second, we know its adverse effect profile. It is safe. Use it. Only thing, newer drugs came with other advantages, so we're not using it, but it can be used in other situations. Okay, good question. Yes.
Repurposing only for using it for same condition, or we can even use for other conditions?
Other conditions. Other conditions.
If we use it for other conditions, it is considered as a new drug.
Yeah.
That is the definition of the.
Yeah.
So I think that is a different.
Right. Okay, so let's go to objectives now in a trial. Okay, quickly. Primary objective must. So the primary objective must be clearly defined, and the primary objective determines the sample size. So a common question is your trial powered adequately for your primary objective? I'll repeat again. Is your trial powered adequately for your primary objective? Remember, Bangalore going to see Taj Mahal. Okay, keep that in mind. That's your primary objective. Okay, so that determines the sample size. Secondary objectives must be defined a priori and not after you get the results. So it's called a post hoc fishing expedition is not allowed, should not be done. Okay, what is randomization?
Sir,
you have a question? Yeah, go ahead. Yes.
Sir, yesterday you explained about the primary objective and secondary objective. Primary objective, under the heading of the primary objective, you explained statistically
Powered.
Yes. So please can you explain? Yesterday you told, today you will elaborate that part, primary and secondary.
Okay, I thought I did it yesterday, but I'll do it again now, no problem. Okay, so you are looking, let's take an example again from cardiology. Okay, you are looking at a drug, new drug, okay, which has to reduce mortality. That is your primary objective. Okay, and therefore you calculate your sample size for mortality. So going backwards, you will look at literature and say, if this drug was not there, what is the rate of mortality? What is the possible effect of this drug? That is known as the effect size, the difference that you see. And you calculate your sample size. So your trial's primary objective is whether this drug can reduce mortality. Okay, and that is your primary objective. And then you must have a minimum of 80% power for that. Fine, you can have more, which is better. You don't need 95% power. Some people overdo it. 80, 85, 90, somewhere between that for a trial is enough. So that is your primary objective, doctor. Okay, and then you will ensure you are getting that. And then let me also look at other objectives. Few other things I want to see. Fair enough? Okay. All right. So what is randomization? Okay, and what do we get for randomization? Randomization is a process of assigning patients to treatment using a random process. Now, I'm going to blank this for a while, and if I ask you, what is random process and what are random numbers? If you can explain that, it is not random anymore. The idea is there's no logic in it. Nature is random. Our mind is not random. We always make patterns. Therefore, we cannot generate random numbers. Okay, how do they generate random numbers? Actually, I don't know. and maybe there's a system, maybe we should ask a statistician about that. Okay, so you must not be able to predict it. That is what random is. And our mind is exactly the opposite. We always go with patterns. We are teaching machines these patterns now. And that's what machines are able to do. That is machine learning, and that is AI now. Okay, that is artificial intelligence. Okay, friends, so that is randomization. Okay, and I'll tell you more about it. So we need to have at least one control treatment and one test treatment for randomization to occur. And treatments administered are selected by this random process. You get treatment, you get control. Okay, it goes that way. Why go to all this trouble? Why go? What is the purpose of randomization? And I'm going to show you the effect of randomization very soon. Okay, this is to produce comparable groups and a very, very, very important bias that comes in with coming to that. Okay, very, very, very important selection bias that comes in is called selection bias. All normal, good, meaning human beings like all of us are biased. Okay, I'll repeat that. All normal, well-meaning, good, ethical people like all of us are biased. So we cannot decide treatments. We need a random process. So randomization. See, previously I told you we need to, for case control, we need to reduce recall bias. You know what we're going to do with randomization? We're going to eliminate random selection bias. Eliminate, remove it. Not reduce it and try to adjust, thoda adjust kar do. No. Remove it. So why do you want to do this? Because at the end of it, whatever outcome or benefit we are seeing with the treatment is because of what? Is because of the treatment and nothing else. Nothing else. I didn't do cohort to explain confounders, but maybe I'll go back to those slides a little later and explain that to you. Okay. So another question that was asked for me, because my thesis was a randomized control trial. So they asked me all methodological questions, and my thesis paper was also published in the Lancet. I don't have time to show that to you. So that's the thing that McMaster University does. They make you really work on something really useful and meaningful, and there's no final exams, there's no theory, there's no mugging up and going and vomiting there, right? And they'll give you occasional surprise tests, but that's okay. But it's all about working, and like what you people did yesterday, we gave you a little concept, we gave you guidelines, sit and work, collaborate with people. So anyway, so coming back, so this is the next question that was asked: what does randomization achieve, right? So now, before that, let me tell you what are confounders. Confounders are those phenomena or things or factors that affect the outcome. They are in the pathway. They modify the outcome. So you need to remove that. In cohort studies, listen very carefully. In cohort studies, we reduce confounders by stratification, matching, and statistical adjustment. Write this down, please. In cohort studies, we reduce confounding or confounders by stratification, matching, and statistical adjustment. We do regression analysis. Okay, that's what we do in cohort studies. So what are we doing? Okay, write it down, please. I'll do that. Okay. In cohort studies, we reduce confounding by stratification, matching, and statistical adjustment, in bracket regression analysis. Okay, and if you want to write more, you can say multiple linear and multiple logistic regression analysis. Multiple linear and multiple logistic regression analysis. That's what we do in cohort studies. To do what? After all that drama, we are only reducing confounding. So to do that, what do we need to do in a cohort study? We have to measure all confounders. How many confounders? 8, 10, 12, 13, 24, whatever. It goes on and on. And so cohort studies are very difficult to both conduct as well as to analyze. I mean, high quality cohort studies I'm talking about. Time permitting, I will show you some examples. Okay, now we are talking randomization. Let's get back. What does randomization help you with? Right? It helps or it protects against. This is the next line is magical, let me tell you. Next line is magical. Protects against both known and unknown confounders. Okay, this is magical. There's nothing else that will help you with this, friends. Okay, in a cohort study, you have to measure all known confounders. You have measurement errors, you have all kinds of things happening, right? And what do you do about confounders that you don't know about? So let us say for cancers, how many confounders are there? Or how many risk factors are there? Let's look at it that way. 6, 8, 10, 12, 14, 34. We can go on and on. Okay, and of course, there are so many that we still don't know. Every year we are adding more and more knowledge in terms of cancers, and for that matter, infections and other things. Okay, so randomization is the only method, and this is magical. If you understand this, you've got randomization. Okay, known and unknown confounders, and therefore, what is the gift we get? We get a balance of prognosis between the treatment groups. That means the two treatment groups are exactly the same, and what is the only difference? The intervention that you are giving. The intervention that you are giving is the only difference. So this slide for me is gold or platinum maybe. I like gold better than platinum. Okay, I'll keep it like this. Okay, so these concepts are critical. Okay, and this was a question that was asked, and I don't think I did a great job in explaining balance of prognosis. I was learning that time. Okay, randomization, methods of randomization. There's something called fixed. The randomization is the same throughout the trial. Okay, then we also have adaptive randomization, which changes during the trial. Now, fixed allocation randomization, you have simple, block and stratified randomization. Okay, adaptive, there are many. Towards the end of this I will tell you a little bit. Okay, and this is what we have to do. Now I'm going to show you some magic again in the next slide, which is the impact of good randomization. This paper is from the HOT trial. HOT means hypertension optimal treatment trial, 1990s in the Lancet. Okay, and I'm deliberately using this. Okay, so this is not a drug trial, this was a strategy trial. How much should we reduce diastolic blood pressure? Now we know lower is better, because people said, oh, if you reduce it too much, that is not good. Okay, should we reduce it less than 90, less than 85 or less than 80? What are the sample size in the trial, please? So you can use any drug but achieve this outcome, achieve this blood pressure or maintain it at that. Okay, should be less than 80 this group. This group is randomized to less than 85, that means 85 to 90, and this group is 90 to 85. Got it? Okay. What are the sample size in the trial? 6,000, 6,000, 6,000. Totally 18,600 and something, 18,700 people. Okay. Now look at the look at how similar the groups are. Look at the age. This looks like a typo. Okay. 61.5, standard deviation 7.5, 61.5, 7.5, 61.5, 7.5. Too much, too good to be true. It is true. Okay. Look at BMI 28.4, 28.5, 28.4. What else do you want to see? Previous, let's say smokers 15.9, 15.8, 15.9. Previous MI 1.6, 1.5, 1.5. So friends, everything is similar, not same. It's similar except what? That the blood pressure targets are different. Okay, so then you get the clean answer. So even this trial said that and lower the better. Okay, let's look at quickly trial designs. So what I showed you just now, what we discussed so far is very important, randomization and the impact of randomization. Okay, let's look at trial design. Your trial design depends on the research question. The commonly used ones are parallel group RCT, I will show that to you, a crossover design, then you have a cluster randomized trial, we have a factorial trial, then we have pragmatic trial using a probe design. Probe stands for prospective, randomized, open, blinded evaluation. If you want to write this down, prospective, randomized, open. The trial is open but blinded evaluation. The evaluators are blinded. So this is called the probe design. You can try this out. You can use this design. When you can't blind easily, use this, but the outcome assessors are blinded. Okay, they may be assessing biomarkers or ECGs or PET scans or whatever, right? There are a few other trial designs, I'll mention it briefly. There is something called superiority equivalence or non-inferiority designs, or it's more hypothesis. And more recently, we are using adaptive study designs. So this is almost all the common trial designs. There are a few others in between, and I will give you a listing of the adaptive designs. Okay, parallel design, we're all familiar with this. Participants who fulfill the eligibility criteria and give consent, right? They are randomized. This is called allocation ratio. Just like in case control designs, okay, 1:1 commonest that we do. You can have unequal allocation ratio for similar reasons. Okay, the drug is too expensive, too toxic, have more controls. Difficult or allocate that way. That means not get more controls. You won't know who's control and who's thing, right? Okay, so they continue in the same arm. That's why it's called a parallel design. Now, we get confused between allocation concealment and blinding. Now, I'll explain this to you as best as I can. I've explained this hundreds of times, but still you will be confused. Don't worry. Don't worry, little later. So don't be upset if you didn't get it right away. It took me a long time to get this. Okay. Now, we have randomized. Randomization is done at the start of the trial. So, where does patient number 1 go? Where does patient number 1700 go? Where does patient number 4312 go? Is all determined at the first time. Okay, it's determined. But protecting that till the patient is randomized and which treatment they are going to is called allocation concealment. And here is a more formal definition. Protecting the sanctity of randomization until the participant is randomized. Sorry, my slide still has subject over there, I have to update it. Till the participant is randomized. Or in other words, not revealing the treatment allocation till randomization. Nobody should know what treatment, even if it's a blinded, if it's an open trial, even if it is an open trial. Okay. So, simple process of allocation concealment is sealed envelopes. Sealed envelopes are made and kept, and then you pull it out. Okay, this patient gets radiotherapy, this patient gets only medical treatment, this patient gets a procedure, or this person gets this drug, that person gets that drug. Okay, sealed envelopes. Do not use this. It's a method. Do not use this. Why? Particularly in open trials. It's the commonest. Sorry, it's not the commonest. It's the easiest. Sorry, it's not the commonest. I'll take it back. It's the easiest to do in terms of randomization. And sorry, in terms of allocating, not randomization. Randomization is already done. In terms of allocation. Why? Okay, let us assume one patient has to get radiotherapy versus one patient has to get surgery. Okay, let's say it's cancer. You pull this out and then say patient has to get surgery. Oh, this patient is elderly, he's got so many risk factors, but fulfills eligibility criteria. That's why it's come in. You are worried because why? You are a good doctor. You are empathetic. You tell your assistant, "Dusra wala nikalo na. Put it back, open." Who knows? Nobody knows. You're putting it back. You're breaking the sequence. You're doing that, right? It happened to one of our trials. About a quarter of our way through the trial, we realized things are going crazy. Because one was an open one which involved 24-hour infusion. I'll complete this, madam. I'll complete this. Okay. And therefore, what people do is they do that. So therefore, don't use sealed envelopes. So don't ask a question on sealed envelopes, madam.
No, I'm not asking that. I'm asking that how it is revealed, like when it is once they have been given some, kind of.
No, you open the sealed envelope. It's just like how we get our OTP or our PIN number from banks. No, you get it like that. Opaque envelope. You open it, you tear it open and see. This one is surgery. This one is medical treatment. Then you keep it back, and you take the next one. The computer will know that you messed it up, but they will think. So therefore, you know what? Only for theoretical purposes, I'm telling you, do not do this. Let's move on. Okay, for this reason. It's easy. Okay, the next one is a random generated sequence with an independent person. Okay, this I have done for my own students in small studies, small faculty studies also you can do this. So statistician gets this, and then you have a good friend in the engineering college. Keep that file there, little far away in the campus, or leave it in Jaipur. So patient is eligible, you call that person, that statistician doesn't, or that person engineer doesn't care about this. So he or she will take out one and say, okay, this is this. That's it, no discussions. So this is a possibility, but still there is a problem. You can sweet talk. Hey, kya bata na? No, we'll do the next one because this has happened like this. So that's also a problem, but this is so as long as that person is tough, you can manage. Okay. So the first one, sorry, I'll go back. The sealed envelope, I do not recommend. The preparing a file and keeping it in a remote location, calling up to find out, or sending an email to find out, all that is doable. You can do it, but still there is a little chance. Okay, go completely electronic, and these days you can do it without any cost. Okay, now for sophisticated multi-center studies, we do what is called central randomization. We always do this. Initially it was IVRS. All of you are familiar with IVRS. Now we always use IWRS. W is for web now. We go to the computer and we do it. Okay, blinding, withholding the knowledge of treatment allocation throughout the trial until the patient is followed up. So for a patient, advantage for a patient, there is some psychological benefit in blinding, right? They think they are getting the treatment. Okay, so they continue coming. Okay, the second one, right? If the patient knows they're getting placebo or standard of care, they will not come. All right. So for the investigator and evaluator, this is very important, and I'm introducing another bias for you. This is called observer expectancy bias. Of the 250 odd biases, this is one bias. Observer means I'm observing something. I expect this. I know this is getting treatment. No, your blood pressure is actually low. No, your quality of life is better. Why are you telling? You got it? You expect this to work, right? And this is not fraud, by the way. These are not bad people. They are not manipulating. This is normal. It happens. So remove that. Okay. Another one is ascertainment bias. You will expect an outcome to happen in the placebo arm if it is not blinded. Okay, and the other way around. Okay. Okay. This is theory. Single blind, patient, double blind. We'll skip this. You know all this. Okay. Let's go to analyzing results. Yes. Yeah.
Sir, if the research question is about reducing deaths, so design wise, will it be superiority trial or parallel?
We'll come to that. Okay. We will not yet come there. So we're doing kind of part 1 of RCTs. Okay. How do you approach analysis? Okay. One is called intention to treat. The other one is per protocol. There will be lots of questions on this. So listen very carefully and understand as much as you can. It takes months of thinking to figure this out. Okay, so let's not try to answer all the questions now. I'm not telling I'm not ready to answer your questions. You got it? Certain things take a little while. For the brightest people, for the people who are listening the most intently also. Intention to treat. All patients are analyzed in the group allotted even if they did not take the treatment or follow the protocol completely. When we do this, randomization is maintained and all the statistical tests are valid. Therefore, always follow intention to treat when possible. Per protocol is we analyze only those who followed the protocol. And the definition of following the protocol must be stated in advance. Okay, now there are all kinds of modifications to this. Okay, there is something called modified intent to treat, then there is a safety protocol, adequately treated protocol. All this definition must be stated in the protocol before your first patient is randomized. Okay, so now we have completed the data, and we've collected the data, and we're going to analyze it, and we're looking at measures of effect. Okay, we are trying to find out the difference between the two groups. We're trying to look at the difference between the two groups and also to assess the magnitude of the relationship. And this is expressed as relative or absolute. Okay, relative measures or absolute measures. For relative measures, we have relative risk and what is numerator denominator? Previously we also discussed it. We have odds ratios, and in a clinical trial or in an RCT we use hazard ratios. Using survival analysis we use hazard ratios. For absolute measures of effect, we have risk difference and number needed to treat. Clinicians love this, number needed to treat, where we calculate the risk difference. Okay, so this is theory now. So let us look at actual results. Let's go to this 2x2 table. Outcome, no outcome, new drug and control. Okay, ABCD, ABCD. I'll keep this as simple as possible. Okay, this is easy, right? This 2x2 table. Okay, now we calculate what is known as experimental and control event rates. Event rates compute the measure of risk. What do we mean by, there are different types of event rates. The first event rate is called the experimental event rate, and then the control event rate. That means how many events occurred in the experimental group and in the control group. But we'll see the formula for that. Very simple. Okay, the proportion of people with the intervention who had the outcome. How many people had the intervention? A plus B. How many had the outcome? Only A. B did not have the outcome, correct? So this is the experimental event rate. Control event rate is the same thing, C divided by C plus D. People who did not have the intervention who developed the outcome. So the so the relative risk is the ratio of the incidence of outcomes in those who had the treatment compared to those who did not have the treatment. So relative risk is experimental event rate over the control event rate, and relative risk applies to cohort study or a randomized control trial. Cohort study or a randomized control trial. Okay. So, but what do we use? We use the relative risk reduction. Relative risk reduction, a little bit of theory, is the amount of risk reduction compared to the baseline risk or the relative risk. Or to put it in other words, the risk reduction with the new therapy to the risk without the new therapy. So one minus the other. So this is the formula. Relative risk reduction is experimental event rate minus the control event rate. And what is baseline? Control event rate. So in epidemiology, the denominator is always important. We need to know what that is. Okay. So this is control event rate. Now that is a bit of theory. Let's look at numbers. Let's take a trial, actual trial. What are the sample size of this trial?
11,500. Placebo? No, that will be double. 22,992 total.
Right. Right. So close to 23,000. That is the sample size of the trial. Now look at the first row there. Let's assume these outcomes are bad outcomes. Recurrence of cancer or death or MI or stroke or developed Alzheimer's, whatever. Now is your new drug good? No, that's all data I have for you. Is this good or not?
I think it is good because it's 50%, almost less than 50%. Outcome is, what is the outcome you are looking
Bad
for?
outcomes.
Achha, it is bad outcome.
Yeah, I just told you bad outcomes.
Then
Bad outcomes.
it's good.
The correct answer is, it seems to be good. Tell me more. It seems to be good. It seems to go in the right direction. Tell me more. Based on these numbers, I am not going to prescribe this drug. Correct? Tell me more. What more you want? Is this statistically significant? So we need to now calculate the effect size and check whether it is statistically significant or not. Okay. So experimental event rate, A by A plus B, if you do all that, you get those numbers. Okay. Control event rate, you get the numbers. Relative risk, that is the formula, you get this number 0.626. So your relative risk is 0.626. What does that mean? Let's take it as 0.63. If it is 0.63,
40% less chance of getting the disease if you exposed
compared to placebo. To be precise, it is 37%, not 40%. To be precise, okay? Okay, 63. Okay, there we go. So let's calculate relative risk reduction. Experimental event rate minus control event rate divided by control event rate. If you do all this, you get your 37%. Did you get it? Okay. So this is relative risk reduction. Here's your absolute risk reduction. Absolute risk reduction is the absolute difference between experimental event rate and control event rate, and this is what we do, and we get this number 0.0047. Okay, so your absolute risk reduction is 0.0047, and this is used to calculate the number needed to treat. NNT, or number needed to treat, is the reciprocal of the absolute risk reduction, 1 divided by ARR, which is 1 divided by 0.0047 equals 212. 1 divided by 0.0047 is 212. Can one of you interpret NNT, this number 212? So first question is, do you want a big NNT or small NNT? Small. So 2 people want small. How many people want a big NNT? How many people want lunch right now? Okay, so the meaning of NNT is we need to treat 212 patients with that new drug, with that particular dose for that duration to prevent one of those events that you measured. That is the meaning. So smaller the NNT, better it is. So I need to only treat 10 patients to reduce one death. Wow, fantastic if you get an NNT like 10 for thing. But it's usually, numbers like this. Okay. So for clinicians, it's easy to decide on benefit and risk of the treatment. Okay. Time for example, and to teach you some other statistics in clinical trials. So this is the first trial that I did. It is an international trial.
Can we, because when they are going to do the study, how will they determine in advance all this? They have to have some study to come to this number.
Okay, this number, madam, you get after the study.
After the study.
So what you do before the study, what we'll do before the study is, how do I know I need 23,000 people for the trial? Yes. That is what I have to decide. I need 23,000 people. How much of time do I have? How many centers do I need? How many cases are there per center? All this we decide. We take months to do this. We sit in rooms like this, and there will be 20-30 people sitting. There will be at least one statistician, sometimes 2 statisticians. We sit and discuss this. So we have to determine this in advance. And that is based on what is standard of care right now. What is the control event rate? How good is this drug based on smaller studies that have been done? Okay, what is the effect size that I get? So therefore, we actually do sample size estimation, not calculation. Calculation means you get a correct number. You only estimate. We need these many patients to get this. Okay, and while the trial is going on, for big trials like this, we have a data safety monitoring board who is looking at unblinded data, and then they determine that, okay, event rates, they are looking at event rates by treatment and placebo. That's the only group in the world, 4 or 5 people usually, who are looking at it. Everybody else is blinded, including the PI and everyone else, ethics committee, everybody is blinded. Sometimes ethics committees, if you people are in ethics committees, please don't ask DSMB results. Okay, interim DSMB results, unless there is a major problem. Okay, ethics committees sometimes become political committees. right, which is wrong. Some of you will become ethics committee members if you not already are. So don't ask for interim results. Okay, they say no, otherwise we cannot do this in this. I want to know results in this center. Nonsense that is. Okay, right? There are 300 centers around the world. What is going to be different in your center? Okay. Yeah. Anyway, let's come back. So to complete your answer, madam, all these things are found before you start the trial. Okay.
So when we are starting the drug, and the sample size is not enough in my hospital, I have to have multicentric study.
Absolutely. Yeah.
Yes. So because it's not going to answer the question.
Absolutely. Correct. And one other thing, if you don't mind, the correct terminology is not multicentric. It is multi-center. Centric means going towards the center. Having many centers means multi-center. Okay, getting our English sorted out. You will see in even good journals on top multi-centric. ICMR studies. I've told them so many times. It's not that's still right. They're still right. Anyway, I mean, what is right, what is wrong, as we'll state it. Okay, shall we move on? Let's look at an example, and I'm going to teach you survival analysis and hazard ratio with an example here. What did I teach you so far? Relative risk reduction, absolute risk reduction. Okay, and NNT, we did all of that. So this is statistics in action. Alright, rather than sitting and doing theories and formulae and all that. Okay, so this is my first trial, and I'll always be very happy when I see this. So this is a low molecular weight heparin, and you will ask me, I never heard of this. Okay, there's a story to this as well. We got a beautiful result with this. I'll show you. Reducing death, MI and strokes. We got a beautiful result with this. Okay, after this, and in that time, this company which was producing this was bought over by another bigger company, and they were not interested in this molecule. And keep in mind, a company spends almost the same amount for marketing that they spend for conducting the trial. They said, we're not interested in this, we're not going to market it. Right? So the drug is not that well known. It's a good drug. Okay? So we completed this, and the Harvard group, the TIMI Harvard group, it was called the TIMI Extract 25, and I'm sure people have heard about Eugene Braunwald. So he was the person, or under his group, they did this with enoxaparin. And enoxaparin had the exact same result. Okay? And enoxaparin, Clexane is the brand name. Okay, that is marketed. That's what is used in this hospital today. It's marketing. Okay, anyway, that's beside. So we can do all the research we want, but it depends on what happens later on. Okay, let's move on. So look at the title itself here, right? Reviparin, a low molecular weight heparin on mortality, reinfarction and strokes in acute myocardial infarction, ST elevation. Okay, so this was a partial factorial study. I'll tell you about factorial later. Okay, partial factorial study. Total sample size was 20,200. 4,600 was part of another study. But the remaining people, 15,570, went to the full factorial design, and 7,700 got reviparin, 7,900 got placebo. Now, look at intention to treat. Using an example, I will teach you intention to treat. Let me use a laser pointer. This mouse keeps going off to sleep. You have to reset it all over again. Too much technology. Right, anyway. Okay, 7,700, 7,790, 7780, 7790. Okay, now 5 people are lost to follow up, and some people died, etc., etc. But look at this here. In the final analysis, the same number, 7,780, 7,790, 7,790. Okay, this is published in the JAMA in 2005. Table, that is figure 1. Table 1 is always baseline characteristics. Can you see now? 7780, 7790. What are all the confounding factors for mortality? Age, onset of symptoms, previous MI, diabetes, hypertension, weight, blood pressure, so many we measured, including treatments. Did they get thrombolytic therapy? Did they get aspirin? So these are all the confounders. Or in other words, these are factors that affect outcomes. What do I want to do with randomization? I want to make sure they are equal in both arms. Equal in both arms. Can you see now? Age 58.9, 59. Okay, previous MI 7.6%, 7.3%. Systolic blood pressure 127.8, 127.5. Look at how beautifully it's matched. Okay, what else you want to see? Let's look at thrombolytic therapy. 73%, 72.9%, 0.1% less. So these two people are exactly the same. Exactly the same. What is different? What is different is in line 1. This one got reviparin, this one got placebo. Nobody knows who got what. Identical syringe. We handle the drugs, and for the first time we imported drugs in 2001. It came from Germany, and then fascinating experience. We've written articles about how we did this study. Okay, so this is reviparin placebo. Let's look at outcomes now. Follow me carefully. Okay, so I have, see, this is one other way for you to teach as well. What do you see there? You see only the title and you don't see any numbers. Take your listeners step by step. Okay, let's look at sample size first. Sample size is 7780, 7790. What are the outcomes? Can you recall the outcomes? Death, reinfarction and strokes, right? Death, MI or stroke. Out of 7,780, 9.6% had death, MI or stroke. Here it is 11%. Here are the actual numbers. Here are your percentages. Okay, and this is at 7 days. We follow them up for 7 days, and then we construct what is known as the survival curve, the Kaplan-Meier curve, right? And we compute the hazard ratio, and we adjust the or we account for any other confounders using Cox proportional hazards model, and we get the hazard ratio. The hazard ratio is 0.87, no p-value. Please interpret 0.87 and tell me if it is statistically significant or not, or will you use this drug in your patient? 0.87. Who wants to interpret this, please? Hands up. We'll give the we'll give the younger people a little more chance, madam. I know you know the answer. Okay, come on. Somebody in that corner there. Somebody is watching their phone. The gentleman with the beard there. Tell us what is 0.87. Quickly tell IDK so we can go. Nobody will be angry. Very good. This side, last person in this row. Next person, you spoke a lot. A person next to you here, I can't see him. He's hiding from me. Your neighbor. 0.87. What does it mean?
I don't know.
Okay. Just the other time we looked at 0.63 and we said something, no? Okay, one of you, come, tell.
13% of.
Yeah, who's speaking? I can't hear who's speaking. Who's talking? Okay, tell us.
There is a 13% of patients who received reviparin had less number compared to.
No, it's not 13% of patients. It is not 13% of patients. What is?
Reduction.
Come, tell the full sentence. Try the full sentence. Doesn't matter. Try.
Reduction in the death, MI or stroke.
Very good. Compared to?
Compared to who received placebo.
Now say that again. It's not 13% patients. Got it? Okay, now tell again. Correct. Now you got it.
There is a 13% reduction in the death, MI or strokes in patients who received reviparin compared to patients who received placebo.
Excellent. One round of applause for them. Yeah. That clapping was not good enough. Once again. Okay. We are clapping for ourselves, not for him. Okay. To say, okay, this group got the answer right. So I'll say this something similar again. Okay. When patients received reviparin at this dose for 7 days, they had a 13% reduced risk of death, MI or stroke compared to those who did not receive reviparin or placebo. Is that statistically significant? Yes, no, possible. Okay, tell us, Dr. Anupama, why it is statistically significant according to you. That's all data for you there. Here, look at these two numbers. This is not crossing 1.
Yes.
Suppose this was 0.79 and 1.01, it is not significant. All right. So you want p value? There you go. P value is 0.0048. Okay. Okay. So now interim summary of RCTs. Okay. It's a powerful tool. It's called the gold standard for evaluating interventions. Don't do anything else. Don't do anything else. Okay. The research question dictates the RCT design. We've discussed it. Randomization ensures a balance of prognosis. Concealment of allocation and blinding are important design considerations, and then they reduce multiple biases. Okay. And randomization, of course, eliminates known and unknown confounders. Eliminates, not reduces, eliminates known and unknown confounders. I did not show you, but please look up the SPIRIT guidelines available free on how to write a protocol for clinical trials, and consort guidelines on how to report clinical trials. Okay. I didn't have, okay, SPIRIT.
Network.org, that is
Equator.org. Equator.org. Okay. Equator.org gives you all these guidelines free of cost. Okay. SPIRIT to write the protocol, consort to report the clinical trials, and when you do journal clubs, you need to use consort. If you're not using these guidelines in your journal clubs, please start using them. And I didn't mention it, STROB, S-T-R-O-B, STROB for observational studies, and PRISMA for systematic reviews and meta-analysis. Okay, so use these guidelines in your journal clubs. At the end of your presentation, put up these guidelines and say whether your particular study had this or not. Okay, it's very easy for us to sit down here and criticize that trial or that study. Okay, it's not dependent on what you think is right. Find out the guidelines. It's very easy to sit and criticize here. Okay, but do the trial and see. Okay, right? Yes, no study is perfect, but do this. Okay, measurements of treatment effects are relative risk reduction, absolute risk reduction, number needed to treat, and I just introduced, or I told you, hazard ratio. Okay, so we do the Kaplan-Meier curve using survival analysis techniques. Okay, we compute the Kaplan-Meier curve. Okay, so now this is part 1 of RCT is done. Okay, right, let me move on to the next one. Here I have a question. I can't use a placebo. What do? So far I showed you studies that used a placebo. Okay, so we do active control trial. One of you are asking me this, equivalence, non-inferiority. We are coming to that. So we ask, is the new treatment better than the established treatment? Or we can ask another question, rather than better, it is not worse than the established treatment. That is your non-inferiority design. Okay, so the design options are superiority, equivalence, and non-inferiority. So this is a diagram I drew for my master's thesis. It's adapted from the book on clinical epidemiology by David Sackett. But this is a diagram I drew from my thesis. I've actually cut and pasted from there, directly from that PDF. Okay, so let's look at what this means. There are 3 horizontal lines and 5 vertical lines, and there is S and I and all of that. Okay, so let's understand this diagram first. Okay, the bold vertical line is the standard to judge benefit or harm. If it is an odds ratio or hazard ratio, that line is 1. If it's a relative risk, it is 0. It is 0. Okay, right? S is the superiority line. Can you see the dotted line to my left and to your left? Okay, to your left, that is the superiority line. Left of that line, the new treatment is superior to established treatment. Only focus on the horizontal line, only focus on the vertical lines now. 1 bold and 2 dotted lines. Okay, superiority line. Then on the opposite side, you have the I, this is the inferiority line. Right of the inferiority line, the new treatment is inferior to established treatment. What are we doing? Drug A versus drug B, that's what we are looking at. Alright, one drug versus the other drug. Okay, I'll blank this for a moment. When you compare 2 different drugs, you can get it being superior or inferior. Superior or inferior. There are some things in between. That's what we're going to discuss now. Okay. Now there are 5 different options: A, B, C, D and E. This took me a few months to understand. So I'll do my best to explain this. Again, I've explained this hundreds of times. I'll do my best to explain it to you. Again, don't worry too much if you do not get everything now. Okay. So what does the horizontal line mean? The horizontal line, the center of which is the point estimate, and the ends are the upper and lower bounds of the confidence interval. Upper and lower bounds of the confidence interval. Okay. That's what it means. Now, this is the line of inferiority. This is the line of superiority. If you get outcome A, means your new drug is exactly the same as the old drug. You have established equivalence. Don't confuse this with bioequivalence studies that are based on drug levels. That is something else. Okay, that's something else. This is clinical outcomes. Outcome A is extremely difficult to establish, so don't even attempt it. Don't even attempt it. What is option B? It is inferior. Throw away your new drug. Very easy. Are you happy when you get this result? You better be happy, because it's not your money you're losing. You be happy because you have a clear answer that this drug is useless. Okay? Always think, will you use it for your loved one, your immediate family? An inferior drug you want to use? Are you happy throwing it now? Now you're happy. Now she's happy. So when it comes to your own, no, then you have different. Anyways. Now what is C now? C, this confidence interval crosses inferiority. It does not go anywhere near superiority. Ayyo. If you get this, then you hit your head and say, ayyo. That means neither this way nor that way. This is non-determinant. It is not clearly inferior. This is clearly inferior. This is non-determinant. I don't know what to do. Wasted efforts. What is D now? Outcome D. Okay.
Not inferior.
Is it superior?
It is not inferior.
It is not superior. Is it inferior? It is not here. This is non-inferior. This is what we like. This is good. Okay. And if this drug, listen carefully now, if this drug is, it cannot be cheaper. New drugs will not be cheaper. So don't expect that. If this drug has a better treatment regimen, has what should I say, a favorable, this is the word, a favorable safety profile, use it. You can replace your old drug. Use it. Okay. So you are happy with this result D. What is result E? Throw a party. I am so sure. Okay. I am going to use this drug even if it is significantly more expensive. More expensive. I am going to use this. I can throw away the old drug now. Right. So you are happy. So throw a party. Invite me. Okay. When you get a result E. Madam. Okay. Okay. So let's take an example of a non-inferiority trial that we did. I was involved with the study, dabigatran versus warfarin in patients with atrial fibrillation. In the New England Journal, I was one of the authors, somewhere in the middle, because we were a group of about 30 people who were part of this international trial. And this is the first novel oral anticoagulant that showed benefit in or showed non-inferiority over warfarin. So based on this, now treatments have changed actually. Okay, so how do we interpret this? Okay, this is a non-inferiority design. If you read the methods paper and in statistics, you will see that. But this is, keep in mind, this is a general medical journal. Okay, so we have 2 doses of dabigatran. I remember we were discussing this on a very cold day in Stockholm. Some of these things stuck in my head. So we were not sure about 110 versus 150. So we used 2 drugs, both the doses, compared to warfarin. Sample size 18,000. Outcome, stroke or systemic embolism. This is an anticoagulant, right? So look at this now. 182 patients, okay, had stroke or systemic embolism with 110. 134 in 150 and 199 in warfarin. What are our comparisons? We are comparing warfarin with 150, warfarin with dabigatran. So 2 comparisons there. We are also comparing dabigatran 110 with 150. Okay. So what do you think? Which drug is the best?
150 milligram.
Correct. 150 is the best, right? Only 134. Is it now statistically significant is the question. What about 150 versus 110? What about 110 versus warfarin? For everything, so 150 versus warfarin, 134 is less than 199. 182 is also less than 199. I want to know if this is statistically significant or not. So here are the results. Okay. So these are the relative risks that we computed here. So 110 versus warfarin. Can you see this comparison? 150 versus warfarin. 150 versus 110. Now 110 versus warfarin, significant for non-inferiority. For superiority, it is 0.34. That means, interpretation, dear friends, 110 is non-inferior to warfarin, it is not superior to warfarin. Look at this now, 150 versus warfarin. It is non-inferior and superior, both. We were really happy. And 150 versus 110 is also statistically significant. Here are relative risks and confidence intervals if you want to look at it. So conclusion from this, I will read out verbatim the conclusion that we wrote in the New England Journal. There is no non-inferiority written here. People don't understand it. Okay. So this is how we said. We compared 2 doses of dabigatran along with warfarin in patients with atrial fibrillation who were at a risk for stroke. As compared with warfarin, 110 milligrams was associated with similar rates of strokes and systemic embolism and lower rates of bleeding. 150 milligrams was associated with lower rates of strokes and systemic embolism and similar rates of hemorrhage. That means 150 is the best dose to use, and if patient has higher risk for bleeding, you can also use 110. When there is no higher risk for bleeding, use 150.
So this is a catch. There was a similar rate of bleeding. So
yes.
that itself is a risk.
Correct. That's why I told you.
You had to put that rider.
Yeah. Similar rates of hemorrhage. Okay. So now this is now replaced warfarin wherever possible. Okay. Some people can't afford dabigatran, so warfarin is still being used in India. Okay, it's slowly being phased out because now dabigatran generic is available, which is much all. These are the NOACs, as we call them, NOACs, novel oral anticoagulants. Warfarin is the old. Sorry.
DOS, direct acting oral anticoagulant.
Yeah. Okay. So now we have another question now. What is the question we answered before? What if I can't use placebo? I have warfarin. But you know the problems with warfarin, right? With a list of adverse effects and an even longer list of drug-drug and drug-food interactions and INR testing.
Yes.
So in fact, we did a health economics analysis and found that dabigatran is better off in those countries, not in our country, because warfarin is still so much more cheaper in our country. Okay. Now I'm taking.
When you are calculating INR every time, you are spending money, time, and so much of discomfort to the patient, hospitalizing.
Absolutely right.
I think the cost should be similar. I don't know the cost of the
that is why now dabigatran is cost effective. That's what we are saying.
Yes.
Initially it was not.
Yeah.
Now it is. Okay. So shall we move on? So what did we do now? When I can't use a placebo, what do I do? Now I'm taking all the trouble to do a trial. Can I test more than one treatment in the same RCT? When possible, we can. Okay. So can I study the interactions of 2 or more treatments? And is it actually efficient in terms of cost and time? To answer all of these questions, we do the factorial design. I will straight away dive into the study that we did. This is one of my favorite studies and I was involved in this. I was part of the steering committee. Now, when a patient walks into our clinic, they don't come with only elevated cholesterol. They don't come with only hypertension. They seem to have both. Do you want to do 2 separate trials for them? Can I do in the same trial? That's what we looked at. Okay. So this was published in 2016. So that means from This trial took us 11 years to complete. I remember very well, July 2005 was our first meeting to discuss the protocol. That means 1 year prior to that we were still working. So it actually took us 12 years to complete the study. These studies are not easy to do. Okay, and we have to stick on with it. Okay, right.
But what is the title is not saying how blood pressure and cholesterol lowering in persons without cardiovascular disease. So what was the study about?
What do you think it was about?
Is it lifestyle?
That's all. NEJ must publish this.
Is it lifestyle you are talking or what? I'm not clear about from the title.
Correct. Okay. Now.
The title looks incomplete to me.
Correct. Terrible journal this is. We should throw away this journal. Huh? Okay. So people in the New England area, where the New England area, northeast of North America, they think they rule the world. They think they rule the world. Okay, so this is where Harvard is, this is where MIT is, and all of these other big people. So this is their journal. So people who make the rules break the rules. So this is, and by the way, you'll see NEJM papers in one line you'll get a title. That's it. This is at least 2 lines. Okay. Anyways, so they don't follow the consort guidelines for the title. Lancet follows it. JAMA follows it. They don't follow. Okay. So let's not worry about that. Our focus is now to understand factorial designs. So NEJM, I'll tell them, madam, when I meet them next time. No, horrible journal. Madam said you should be banned.
No, I'm not saying
okay. No. Take it. No, you're right in pointing it out. You're right. I appreciate you for pointing out. And I also gave you the background. They don't follow the rules. Okay. Yeah. That's the other thing. That's why they have such a high impact factor.
They never publish negative.
Yeah. There are lots of problems with them. Anyway, our focus now is to understand factorial designs. Okay. So I'm going to skip all this background, and this is called the HOPE-3 trial for patients who have borderline cholesterol and hypertension. Borderline. If they have elevated cholesterol, they have to get statins. If they have hypertension, they have to get, so in borderline. So let's go back to this. Okay. What is the title? The second line is important. Without cardiovascular disease. So this is moderate risk primary prevention, not high risk. High risk, you have to get treatment. This is moderate risk. Moderate risk is the submerged part of the iceberg. The iceberg is still there, we can't see it. That is what our trial was. This used the principle of uncertainty to randomize, to include patients in the trial. Principle of uncertainty means in a medicine department, if there are 10 people in one unit on that OPD day, listen to this carefully, okay? Right? 10 people are there, including residents. They are prescribing antihypertensives and lipid lowering drugs. Okay? If 100 patients come with a particular level of lipids and blood pressure, in the same unit, I'm not even talking unit differences, in the same unit, 5 of the consultants will, or 5 of the doctors there will prescribe, the other 5 will not prescribe because the guidelines are not clear at that time. So this is called clinical equipoise. Please write this word down. Clinical equipoise. EQUI POISE. Clinical equipoise. Okay. Clinical equipoise is the time to conduct a trial. When to do a trial? The timing of a trial is important. Okay, when to do a trial? When you establish clinical equipoise. Some people are saying do this, the other people are saying don't do this. Let us do a trial to find out. We are not talking about a brand new drug which we have to try out against placebo, whatever, right? These are established drugs. One of you was asking repurposing and all that we spoke about. This is not exactly repurposing, let's say clarifying indication. Okay, of course there are some people say you are trying to medicalize the whole people. Hey, listen, you can't see the submerged part of the iceberg. You can't see it, but this is still an iceberg. That means these are people who still have outcomes. So we need to identify them. And consenting them is not easy. And even getting people to participate in trials are not easy. No. Because people are saying, no, at this level I will prescribe. At this level, I will not prescribe. So you must be okay to either prescribe or not prescribe. That is clinical equipoise. You got it, friends? And you need to establish clinical equipoise before you set up a trial and run it. Okay, so this is what we did in the HOPE trial. Let's go forward. Okay, so on one side we have candesartan and hydrochlorothiazide, two blood pressure lowering drugs, one angiotensin receptor blocker, one diuretic compared to placebo. The other side we have rosuvastatin, a high potency statin versus placebo, right? Now this is a 2x2 factorial design, and in group 1, let us say, people get all the treatments. Here they are getting only candesartan, hydrochlorothiazide and placebo. You got it? Candesartan and placebo. Here you tell me what you get here. Rosuvastatin and placebo. What do you get here?
Nothing.
Placebo and placebo. Oh my God, how is that possible? Ethics committee is not going to approve. Will you approve this? Placebo and placebo?
If the indication is not there for high blood pressure, I mean it's not that high.
Then how can you give this here? And why are you doing this here? You don't like these people? This is clinical research. I don't have an answer. We have to do placebo controlled trials. So this is what it is. Rosuvastatin placebo, placebo and placebo. Okay, for those of you designing trials, how do I package the drugs for this? This is called a double dummy design. Okay, so if I get half a day to do only clinical trials, I'll tell you all of that. Okay, but whatever comes to my mind, I am telling you this. So this is a
same or different here?
It will look exactly the same. So this is called a candesartan hydrochlorothiazide placebo and rosuvastatin placebo. So you will feel, the patient will feel that taking the actual drug. That is why it's called a double dummy. And by the way, if it is injection and tablet, you will get injection placebo and tablet placebo.
That's why I'm asking you. I mean,
it looks the same.
I don't know, but were the composition of these placebos same? That's my question.
It is the same.
It is.
Or rather, it looks the same. Not it is the same. It looks the same. Yeah. 1 second. Can you believe I've been talking non-stop from the morning? Okay.
The bottle is very important.
Yeah.
It's really important.
Okay. Thank you. Okay. Now, we follow up these patients. We followed them up for 7 years in India. In HOPE 3 trial, we followed up the patients for 7 years. Other trials, other countries, they started a little late. So, on average, they were followed up for 5 years. Why do you follow them up for 5 years? You think it's easy to do these trials? Very difficult. We followed up for 5 years and we got the results. Okay. Now, how do we analyze this? One option is to analyze each of the cells separately. I'll go back here. Okay. I can analyze this versus this, which will give me the effect of both drugs versus no drug. This versus this, rosuvastatin versus placebo. This versus this is candesartan versus placebo. The analysis is correct but inefficient. Is correct but inefficient. Okay. So what is our approach to analysis? This is analyzing each cell separately. The efficient way of analyzing. So the first trial is like doing 2 separate trials, okay, with half the sample size. 2 separate trials with half the sample size. So the next approach is analyzing simultaneously. This is called analysis at the margins. I'm going to explain this to you. Okay, one treatment, overall one treatment versus the other. So let's go back to a line diagram of this. Okay, so this is candesartan, hydrochlorothiazide and rosuvastatin. Rosuvastatin alone, candesartan alone, none. Okay, now let us add a margin to this. Okay, listen to this carefully. If you get this quickly, you understood factorial trials. The margin here, okay, these 2 groups, these 2 fellows, all of them have got rosuvastatin. All of these fellows did not get rosuvastatin. Now, if I analyze this versus this, what am I getting? Rosuvastatin versus no rosuvastatin. Can I do the same thing on the other margin? Yes. What do I get? all candesartan versus no candesartan. Excellent. Okay, all of these fellows versus all of these fellows. This trial was eventually 12,800 odd people. Let's assume it is 5,000 each. 5. Oh, that makes us 20,000. 2,500. Let's keep it as 20,000 just for analysis. Okay, 5,000, 5,000, 5,000, 5,000. If I analyze this versus this, 5,000 versus 5,000, what is the sample size of my trial? 10,000. If I analyze this versus this, 10,000. This versus this, 10,000. What is my actual sample size? You have 20,000 people, but you're analyzing only half of that. When you analyze along the margin, what is the sample size? 10,000. What is the sample size? Fantastic. What is my total sample size? 20,000. This is analysis along the margin. Okay, fantastic. You got it? Let's move on. Okay, so here are the results. So 4 different analysis. Okay, candesartan hydrochlorothiazide plus rosuvastatin. One group, second group. This is baseline characteristics. Okay, so 3,000, 3,000, 3,000, 3,200 roughly. So totally 12,600, 800. That was the sample size. So can you see it being balanced? This is always table 1. Okay, 65, 65, 65, 65. Wow, beautiful, right? And let's take female sex, 46%, 46%, 46%, 46%. Got it? Balanced. Anything? Diabetes, 6.2, 5.6, 6.0, 5.3. Okay, small numbers, so you will see little imbalance. The moment it goes to thousands, you will see this 87, 87, 86, 87. The moment they are in hundreds, at the decimal point, you will see it going a little bit off. Okay, right. So here are the results. It is too small to see there. I will read it out for you, or no, you can see it. Okay, so let me read out here. This is okay. What are the outcomes? Death, MI, stroke. Now don't worry about co-primary now. Let's not discuss that. Okay. Okay. So death here is 3.6, 3.8, 4.6 and 5.0. Okay. So now our comparison is candesartan hydrochlorothiazide plus rosuvastatin versus placebo gives me a hazard ratio of 0.71. Okay. This one does not cross 1. Therefore, p-value has 2 zeros before the 5, not 1 0, 2 zeros before the 5. So, what is the effect of taking these drugs versus placebo? Here, this number you have to interpret for me. 0.71, what percentage is it now? It's a 29% statistically significant reduction of death, MI or stroke when you take these drugs compared to placebo in those people, half of who would never be treated. Imagine the lives we can save with this when people take these treatments. So we need to do trials like this to prove to people. Otherwise, even among doctors, they are saying you are over medicalizing it. Alright, Baba, you are not identifying people. People who are coming to your OPD, not people who are sitting out there with a blood pressure of 160 by 110. They are not coming to your OPD. Here you have people with moderate blood pressure and they came for what? They came for ankle sprain or they came for toothache. Measure their blood pressure, measure their lipid. That's why you can't screen everybody. Screening is also difficult. People who come to the hospital, you do know. Okay, so this is okay. So let me now explain the survival analysis. Okay, or this is known as the Kaplan-Meier curve. If this is 0, it will start from here and go ahead. The blue line here is combined treatment. Okay, and the red line here is this. Okay, is this, and then 0.71 is 1.72. So this is for the second co-primary. This 0.72, this is what you are seeing here. The difference between this and this. Okay, friends. So that is, I'll blank this for a moment. That is factorial designs when you have two distinct research questions, but those distinct situations happens in the same patient. Okay, they're coming to you with hypertension or just about borderline. Half of them don't get treated. That is called clinical equipoise or clinical equipoise. Okay, so we do difficult. These are not funded by pharma, by the way. Yeah, these are funded by government agencies, and the Canadian government funded this trial, and we have this. So now more people are taking any blood pressure lowering treatment. Okay, and this is the any statin you can give, but as we know, atorvastatin and rosuvastatin are the most potent statins. Give that. You don't have to give rosuvastatin. Okay.
What was your what the levels you have taken in this study for blood pressure and for the?
It's there in the paper, madam. You can look it up. I don't recall it offhand.
No,
so it is a level. No,
which is borderline. That's
exactly.
What that is what I wanted to know. What
it is borderline. I can't remember now.
Okay.
It's given in millimoles in this paper. I can't recall the protocol. But anyway, you can read the paper. Now it should be available free. Okay, but it is that level where half of people in medical college hospitals don't treat. Okay, the other half they treat in the same unit. I'm not even telling unit 1 versus unit 4. Okay, let's move on. Okay, what to do if I cannot blind the treatments? It has to be open label. What to do? But open label has got so many problems. What do I do? Okay, what if I cannot blind? How to evaluate health systems intervention? In a whole district, they are going to do something. Is it working or not working? Okay, how to avoid contamination in behavioral or policy intervention? These are the questions that we ask. The solution is to test the intervention on the entire group. Okay, and keep the groups apart. What design is this? Okay, so we can do cluster RCT to compare interventions allotted to the entire group or to the cluster. Okay, right, not to individuals, and this is to evaluate complex interventions, and they are used in health services research. The groups could be communities, schools, workplaces, hospitals, patients treated by a particular doctor, etc., etc. So this was a trial that I did along with Duke University. We designed this trial. I saw some collaboration with Duke University you have here, right? So, so we did this trial. This is multifaceted interventions to improve treatment with oral anticoagulants, an international cluster randomized trial we did. Okay, this is a 2-arm international cluster randomized controlled trial wherein we used a bunch of interventions, behavioral interventions, not drug intervention, to improve treatment of atrial fibrillation. Okay, so I'm going to introduce, you know what, let's not do that, too much statistics it will become. Okay, so but anyway, let me tell you, we computed the odds ratio, right, and then we looked at time to event analysis of Kaplan-Meier with the log rank test. Okay, we also used Cox proportional hazard models. I'm introducing these things to you because these are the whenever we get a chance to discuss survival analysis, I have a whole 1.5 lecture hour, 1.5 hours lecture on survival analysis. Another time we can do, or we can do it online. Okay, so we computed eventually using hazard ratios and 95% confidence interval. Okay, so our first outcome was, can we improve adherence to anticoagulants in patients with atrial fibrillation? Okay, and here is the Kaplan-Meier curve, and we showed an improvement in, no, this is not survival, in using medications, right? So this was a 1-year adjusted odds ratio of 3.28. That means people who got the intervention, there are a bunch of interventions. We used non-physician health workers, we trained the physicians, we gave guidelines. There is a package of interventions. Okay, one other country in South America and Brazil, they used SMS messages. We do not use SMS messages. Okay, so it is a package of interventions that we used, and when we use these interventions, adherence to medications at the end of 1 year is 228% better compared to without using the interventions. And since we are using behavioral interventions, we randomize the whole hospital. This hospital gets intervention, that hospital does not get intervention. Okay, that's what we did, and those are the results, and we got something pleasant over here. Look at strokes here. Okay, although the numbers are small, there was a 52% statistically significant reduction in strokes. You take anticoagulants, you reduce strokes, right? And this is what we got. Okay, one other question: can I make trials more efficient, ethical, and low cost? Can I get results quicker? That's what we want.
For COVID vaccines, they have been doing it.
right? Yes, yes. Yes, so now another reason in COVID was, firstly there were millions of patients and everybody wanted solutions, everybody agreed to do. Ethics committees met on Sunday, they gave approval on Monday.
Yes, that's what.
How does that happen? Because it is a global emergency. Global emergency. Hypertension and getting a stroke after that is not a global emergency, it's important. Okay, so it is a global emergency. So the solution is to make ongoing changes to the trial. As the trial is going on, we make changes. Based on what? Based on results that are coming. We normally don't do that, but we do this, and this is called adaptive trial designs. Adaptive trial designs use results accumulating in the trial to modify the trial's course, but keep in mind the next line is critical. Based on pre-specified rules. You don't do whatever you feel like. Okay, adaptive designs can be done across all phases. Initially, it was only early phase. You would see our industry colleagues doing that previously, early phase trials. Phase 1, phase 2A, phase 2B, let's do adaptive trials. But late phase confirmatory trials are also done. The classic example is the recovery set of trials done by Oxford University. Okay, I'm lucky enough to know both of the PIs, Martin Landry and Peter Horby. Both of them, I've been in meetings with them. And Martin Landry, is part of another study that I'm working with along with him. So amazing work, amazing work. In a matter of 2 weeks, they got results of one intervention. 2 weeks, can you believe? Because every single hospital in the UK, they had no choice. They had to do the trial. Okay, ethics committee, as I told you, they met Saturday afternoon, on Sunday morning they gave approvals, and then they gave global approvals for the whole country. Go ahead and do it. There was all the delays went on. Okay, anyway, adaptive trials. So they are usually more efficient, more informative, they are ethical, and often better use of time and money. Okay, all this is fantastic. Why are we not doing it more often? Because they require, they also require fewer participants. With all these advantages, why are we not doing more adaptive trials? Because it's more complicated, and you need very, very good trial designs and statistical analysis. So using a diagram, this is the traditional fixed sample design: design, conduct, analyze and report. But in adaptive, you design, you conduct, then you review the results. Then you make changes to the protocol based on what? On rules that you already wrote in the first protocol and it is approved. Based on this rule, rule number 2, I'll do this change. Rule number this, I'll make this change. So we adapt, then we analyze and we report. Okay, here is a list of types of adaptive trials. I will not even read this out to you. The reference is there at the bottom, BMC in 2018, and there is another one, another list over here, all of these. In fact, we have conducted workshops based on these types of designs. Okay. So advantages: statistically improves the power, allows to detect even small effect sizes. It's more ethical. Why is it more ethical? Can somebody figure out?
Because you are able to make changes and help the patient if it is showing some good results on the way only, rather than
even before results, madam.
Yes,
is it still ethical?
Halfway, people change the strategies to kind of
benefit. So even before benefit, if it is either harmful or useless, we stop it earlier.
Yes.
With adaptive trials. Okay. Now more participants can get promising therapies. Okay. Continuing on, we have better understanding of drug effects. We can explore different doses. We can enrich subpopulation. One of the nice examples I have is called population enrichment design. Or it's also called back the winning horse. Okay, you go on. Okay, it's more acceptable to stakeholders, and sponsors love it because it is cheaper, you get it faster, and it's good. What are the disadvantage? Not disadvantage.
Can I share one?
Come back to the previous question we asked about DSMBs and ethical committees.
Ethics committees.
Ethics committees, right.
Because if it's ethical committee, there should be another committee called unethical committee. So you got that. One more thing to learn in research. Sorry, madam, I'm interrupting you. So don't call it ethical committee. If your committee is called ethical committee, then ask where is the unethical committee in our institutions. Okay, ethics committee. No, please don't apologize. For something, in high school I got prize not in maths and physics and biology. Only for English I got prizes. So it always sticks in my head. No, we'll finish her question. Sorry.
So when you talked about DSMBs or data safety monitoring boards, the completion, the ethics committee you said should not be asking for results of the interim analysis. Whereas here you are actually saying that the results of the interim analysis will be used to change the trial. So that means you are saying that the adaptive study design was there a priori.
Correct. Correct.
And that is why the ethics committee will have the right to ask at any time or at specified time details.
Okay, now.
Is it the ethics committee who will ask or the sponsor will decide or who will decide?
No. Okay. I wish I could quickly pull out the stakeholders. They have a nice diagram of stakeholders in a trial and who does what. But anyway, sponsor's job is to make sure the right people are there in the right place to do the right job and provide resources. Ethics committee looks at the ethical aspects of it, right? Okay. And DSMB, who is a DSMB? 5 to 6 members. They are been there, done that people. Okay, they are expert clinicians, they are expert statisticians and expert clinical trialists. Okay, you may not get all these 3 expertise in one person, but even if you get one person here, they will have expertise in the other areas as well. Okay, so they are been there, done that people, and they are very patient people. That's the other thing. Okay, these are all characteristics of a DSMB member. Okay, now. The DSMB will look at unblinded data and look at the overall thing, and then they will say, okay, you can proceed or stop or modify. These are the things the DSMB says. With due respects, I don't think all ethics committee members or all ethics committees have that level of expertise to take these decisions. With humility, let me tell you that I'm on many ethics committees. Only last year, after all these years of doing trials for 24 years, only last year I got onto a DSMB. Okay, you have to be very patient for that. And therefore, what will an ethics committee do when they know these results? I don't think they are empowered enough to take those decisions. However, they can ask for the decisions of the DSMB. Okay, I'll say this with all respect to people. We've had, now all of us here, I don't think we can sit and consult on an aeronautics project. We can't go to engineering college and tell them how to do their engineering job. For that matter, even advanced things like, genetics and other things, we don't know. So we have to be comfortable in saying, I don't know, I don't have expertise in this. Just last week, somebody asked me to do a particular job. I told them, sorry, madam, I don't have expertise in this area. But sir, you have done this, done that. No, madam, I don't. I declined it. I declined that particular thing that they asked me to do. Anyway, so that's important. So I hope with little,
I got
yeah. Yes. Yeah, thank you for, otherwise, people keep, so what will the DSMB say? DSMB will say, this trial can continue. This trial needs to stop for these following reasons. They will say that. They will not give any other reasons. Now, why will a DSMB? Now, since you asked that and we are on this, and it's a nice way to conclude trials as well, because people in this room are going to be on ethics committees. You must get onto ethics committees once that you are that much more knowledgeable. A DSMB will stop a clinical trial for the following reasons. One is for efficacy. Okay, so sorry, prematurely stop a trial. Prematurely stop. I need to underline premature. They'll prematurely stop a trial for the following reasons. One is for efficacy. I showed you HOPE 3 trial. The HOPE 1 trial, it was not called HOPE 1. It was published in the NEJM in 2000 or Lancet, one of the two. Okay, in 2001, that looked at Ramipril versus placebo in secondary prevention. Huge result, 3/4 of the way through the trial. They found a similar result little earlier, but they pushed on for a little more while, and then they showed huge benefit of Ramipril compared to placebo. They said stop the trial. Why stop the trial, Dr. Mohit?
Because it's obviously showing a lot of benefits, so it's no point harming the other group by not giving or counting on placebo.
One reason. Another reason? Correct. You're absolutely right. Be ready to clap for him, okay? So that means keep both your hands free. Yeah. One is, this is showing benefit. This is showing benefit. The other people, we are doing disservice by not giving them. Another reason is, Why wait another 3 months? Tell the world. Here is only 10,000 people. The whole world is millions of people. Get the results out quickly. So 2 reasons why they stop: for benefit. With an example, I am telling you. So I told you, look up that paper. Okay, it's called the Hope Trial. Salim Yusuf is the first author of that paper. I think it is NEJM. It could be Lancet. Okay, one of the two. Right? Second reason for stopping a trial is harm. It is causing more harm than is acceptable. And what is acceptable harm is written in what is called the DSMB charter. It's a separate document altogether. Based on the protocol, they write the DSMB charter, and then there is a way of calculating harm and benefit. Okay, how many standard deviations will we accept? Okay, so these are called monitoring boundaries. There's no time to go into all of that. I'm just mentioning it so that anytime you hear this later, you may want to go learn more about it. Okay, the third reason, one is benefit, one is harm. The third reason,
Side effect. That is already taken.
No benefit. No. Lack of benefit.
it is called futility.
Yeah,
Futility. Okay, these two curves are so together throughout 6 months, 1 year, 2 years, 3 years. So no difference between treatment and control. No point in continuing it. I am sure, or we are sure, the committee is sure, we are not going to get a favorable result. We are not going to get any result, either this way or that way. Stop it for futility, because every day in the trial is number one expensive, and patients are being exposed to treatment. Okay, so we are going to conclude very soon in the next few minutes. Disadvantages of adaptive trial, not disadvantages, I would say challenges, is more complex to design. It takes a long time to start up. Okay, we need lot of simulations. You need excellent statisticians to do that. So to summarize part 2, once again, RCT is the gold standard to evaluate treatments. Eliminates issues with observational studies. I told you about non-inferiority trials. They're getting increasingly common because we seem to have treatments for almost everything these days. So active controlled trials are what we need to do. So all of us should become familiar with non-inferiority designs. Okay, then factorial designs, there are several advantages. Cluster randomized trials, health systems research, adaptive designs brings in efficiency, and that is the end of the morning session. Thank you very much.
For presentation,
A, B, C or D, not
ABC only group and your name. Clearly written your name.
only one name within that.
If you could enough.
Written in this order of presentation is also going to be randomly picked. Here, madam, you pick one. So this is the first presenter. Which group is that?
2.
Okay, so okay.
2 is B, no?
Yeah, 2 is B. So write number 1 next to it. Okay, Anupama, pick one and write number 2 on that. And that group is
3.
Okay, 2, 3. You pick one.
Not fair.
Why?
This is not random.
That's okay.
Because the last one gets only one choice.
That's okay.
Group 1.
This is still a random pick. Okay, group 1 is 3.
3.
And group 4 is 4.
Yes.
Group 4 is
Oh, that is C. Okay.
C. Nice. So this is third presentation.
Group 1 is A, right?
A, 1 or A. So that is 3.
Yes.
So the order is, give me a pen please.
2, 3, 1, 4.
2, 3, 1, 4. Correct. 2, 3, 1, 4. Okay. Okay. So here is what we're going to do now. Have you finished mailing? No. Mail it. Don't modify it. It's okay. Okay. Listen carefully now. This is a huge opportunity to learn. Huge. Okay. So what we learned yesterday, we immediately put into practice. Okay. And you get exactly 10 minutes to present, and at 9 minutes, who's timekeeper? Who's volunteering to be timekeeper? Volunteer, timekeeper. Okay, so he's the timekeeper. Okay, so at preferably this one you can keep track of. Okay, at 9 minutes, Doctor, your name?
Deepak Gupta.
Okay, Dr. Deepak is going to wave out at 9 minutes. Okay, at 10 minutes you stand up. If they continue talking after 10 minutes, we will physically escort them back to their chairs. Okay? No, we are very strict about time. So can you show us how you're going to wave, Dr. Gupta? Okay, just wave out, and you need to acknowledge from here. You just give a nod so that he can stop waving. Okay, all right. Okay, so we're very strict about 10 minutes. After that, we will have, depending on time, okay, a comment, not a question, a comment or a point for improvement, not a question. Okay, I'll explain this again. You can make a comment, this is relevant, your methodology is whatever, good or whatever, okay, and 1 point for improvement. No questions. Okay, no questions, no pointing out mistakes also. We are here to learn. Okay, of course we learn from mistakes, but we don't have time for that. Am I clear? And I will moderate the whole thing. Hold on. I'll moderate the whole thing. Okay, and since we don't have any external faculty, I'm the one man standing judge. Okay, and I'm not related to any of you, and so far nobody has bribed me. Okay, but my pocket is still open. You can meet me on the side. Okay, anyway, jokes apart, I will, because we have a little gift for people, right? So there is a bit of competition here as well, which will be your, and I'm aware that the cohort group, we did not have a lecture, but that's okay. That's okay, so I'll keep that in mind when I'm evaluating. Okay, but the other 3 groups we've had lectures. Okay, and yeah, that's about it. Any questions, anything to clarify? Yes, you had a question.
Should we present it as a proposal or protocol, or like as an already done study?
As a protocol. It's too late in the day you're asking this. Okay, too late. You should have asked this yesterday when I was giving. So this is a proposal, is like Shark Tank. Shark Tank, okay. So reviewers are sitting there, they are going to review you and give you the grant to do the study. Look at it like that. Okay, so that's what it's about. Any other questions? Okay, you will also be judged on the quality of your slides, the way you stated your research question, and before that the need for the study, research question, your methodology, your statistics, whatever. Okay, okay, so the order is going to be 2, 3, 1, 4. So there is only 1, 2, 3, 4, 5, 6, 7 people from group 2 there, that group. No, this is group 1, that is group 2 who are sitting there. So anyway, many people either did not put their names here or they have gone somewhere. Okay, so, okay, pick one name for group 2, the person who's going to present. Can you get their slide up please, group 2, slide.
Dr. Kushwant.
Dr. Kushwant, yay. Okay, big round of applause for Kushwant. Okay, as soon as, okay, your slides are out, so your time starts now.
Good afternoon everyone. I am from group 2 and we will be presenting a proposal on...
Okay, hold on a second. Hey, rest of you have to listen very carefully because you're going to be picked at random to make a comment. Don't say I did not listen. Okay, we'll give you a few seconds extra. Go ahead.
Our research question is prevalence of anxiety and depression among first semester students in medical universities of Jaipur, Rajasthan. And it will be a cross-section study. Group name is Inside Pursuers and group members are Dr. Shobna Bhatia, myself, Dr. Rajesh Kumar Sharma, Dr. Bhumi Chaturvedi, Dr. Sankar Rathod, Dr. Manoj Mathur, Dr. Rani, Dr. Mamta Yadav, Dr. Sachin, Dr. Sanjeev, Mr. Ayush, Mr. Surya, Mr. Damini and Ms. Ritisha. So why do we need this study? So when we did a literature search, we found that prevalence of anxiety among medical students is a global concern. A systematic review was done and it found out that the mean prevalence of anxiety and depression in university student is approximately 30%. That means that almost every third student is suffering from anxiety and depression. So that is a concern. So we have data from Middle East and North America, Asia and South America and Europe. And if we look at this data, almost they are near 30%. So this global statement that 1/3 of the students are suffering is quite valid. But when we searched the literature, there was no much data available for the Indian, especially for Rajasthan. We also search the literature about depression. So depression is also quite prevalent, and it is also about 30.6%. So citing this lack of data, we decided that we will do a study, and as the student take admission when he is just about beginning his medical career, they are anxious because they are far from home and environment is changing, friends are changing, everything is new for them. So we decided that we will be doing this study in the first semester with the students, and we will include all the universities of Jaipur. So the study objectives. So primary objective is estimation of prevalence of anxiety and depression in the first semester medical students at all medical universities of Jaipur. The secondary objectives will be estimation of academic risk factors associated with anxiety and depression. So academic risk factor means related to the studies. It might be teacher, it might be the curriculum, it might be that they are unable to learn, there might be some practical problems or challenges which they are facing. Also, we will be studying the non-academic risk factors such as food, language, having no friends, or maybe substance abuse, etc. And what else we can find out during the study. So the study method, inclusion criteria will be first semester medical students of 18 years or above in the medical university of Jaipur, Rajasthan. Exclusion criteria, already a diagnosed case of anxiety or depression or on medication or suffering from some serious medical condition and is not willing to participate in the study. The study procedure will be, first of all, we will seek permission from the authorities, which includes permission from our university authorities and other 4 medical universities of Jaipur. Then we will create a Google form which will be based on a questionnaire, and this questionnaire will be questionnaire such as GAD-7, which is a global anxiety and depression 7 score, and patient health questionnaire, and SF-36. This Google form after creation will be sent to all the students of the first semester of the medical universities of Rajasthan. And during this process, we will be selecting nodal persons at all the medical universities so that they can help in collection of data. There would be a time bound. This would be a time bound process, and every student will be given 48 hours to fill the form and return the form. As much of the personal data is involved, and this is an ethical concern, and student might be he might not be willing to reveal that personal details, such as if somebody is using drugs or something like that. It can be a very serious situation might arise from this. So we will keep the data anonymized, and we will not collect personal data. All the data will be anonymized. We will not be collecting the names or email addresses of the students. And this is possible in Google Forms. All the data after collection will be analyzed and interpreted, and it will be published. Thank you.
Okay. All right, very good. So, okay, I'm going to pick from group 1, this is group 2, right? So, either a comment or an area for improvement. No questions to him, he's not going to reply anything, okay? No questions and no adverse remarks, okay? I'm just picking Dr. Deepak. Where is Deepak? Oh, yourself. Huh? Oh, you were busy with that. You're looking at the clock whether it's running. Okay, no. You have to do double duty. Okay, this time so next time onwards. No, that will go on. This is second. Okay, let's. Okay, Mansi, Group C, Group 3, Mansi. Where's Mansi? Mansi, listen. Comment or area for improvement. Don't say I was not listening. Listen.
Are we able to calculate prevalence in case control study?
No, it's a cross.
Oh, hold on. We're getting it all wrong. You are not supposed to ask a question. What did you like about the presentation? What was nice? Remember, they had less than 24 hours to work on it, like everybody else. What did you like about it? Or if you found an area that can be improved, suggest that. For which you have to listen very carefully.
The presentation was very nice. The topic selected is an.
What was nice about the presentation?
The topic is good.
Okay.
It's a money topic.
Right. Very good.
And the way it has been presented with the logos and all the titles and headings, they have the serial way what you taught us, they have maintained that sequence also.
Very good.
And multiple institutes are involved, so we expect it will be with a large sample size we are expecting.
Right. Okay, good. Please sit down. Let me ask another person, Dr. Maharaj Singh, Group D, for a comment, compliment, or anything to improve.
Actually, sir, the presentation is good. As what we have suggested, they have completed the end set of issues
Okay.
properly, as per my knowledge. Methodology is also up to the mark.
Okay.
And my suggestion is that they have limited their studies only up to Jaipur.
Okay.
Included all over the Rajasthan medical institute. The result
Okay.
will be much more.
Okay, much more useful. Okay, please take a seat. Anybody else? Random picking is over. Anybody else wants to make a comment or a compliment? Yes?
Somewhat, the presentation was good, really.
What was good about presentation?
It can be
Sorry?
need of the study.
No, hold on. You said presentation was good. What was good about the presentation? Okay, listen now. I deliberately didn't ask the other people. When we communicate, we have to be clear and specific. So today we had lunch. Yesterday we had lunch here. Very nice lunch. Okay, so while walking out, we just said, lunch was good and we went. Okay. On the other hand, suppose we had said, the dal that was made was really nice. The paneer, was, it had a nice flavor in it. It was really good. Of course, my favorite was the papad there and whatever. And thank you for the dessert as well. It was, you're specific. And all it takes is one sentence. Alright, so now you just can't get away by saying presentation. What was good about the presentation?
Understood, sir.
Good.
Presentation was good as he highlighted the introduction or the background of the study.
Right.
And then about the methodology also, he has covered most of things.
Okay.
Little description need for the tool and for the data collections in detail.
Little more detail. Yeah.
And similarly in need also, they have to give some data. They have just mentioned that there is no data about state or other. I don't think so. So
okay. Little more data needs to be added.
Then tool data collection I told, and then about some statistics.
How to analyze this?
Some little description and what.
Okay. All right. Good. Excellent. So we are also learning communication. See, as doctors and even more as researchers, we need to communicate better. So now what he did is he bounced off the communication from me, from here to him and to the group. That is easy to do. Okay, next time onwards, not him, next time onwards, you need to give, and also he spoke in the second person. Second person means they did. Okay. So now next you have to talk directly to the group and he is representing the group, and you speak in the first person. Okay. So when we communicate, right, we'll do that. Okay. Anyone else? You had your hand up. You wanted to?
I want to say that इन्होंने जो topic लिया है ना, वो लिया है first semester student का.
You tell him directly now. You tell him directly. What's his name?
Sorry, sir.
Kushwant. Okay. Hold on. One other thing when we communicate and in human relations, okay, is using people's names. Okay, I was really hoping that all of you would have a large badge here. I requested, but some of you have, some don't, so I really can't. So I still try and remember your names. But anyway, Dale Carnegie, rings a bell for anybody?
Yes.
Okay, about 100 years ago, literally, he said, the name of a person, listen carefully, the name of a person is the sweetest sound in the world to them. Anupama is the sweetest sound in the world to them, to her. Okay, isn't it? Right? So please make an effort to use people's names. Okay, so that is Dr. Kushwant. Okay, now speak to Dr. Kushwant directly. I am going this side. You talk to him. Okay, Dr. Kushwant.
Yes, आपका जो टॉपिक है ना, बेसिकली आपने फर्स्ट सेमेस्टर को बच्चों को चूज किया है. ये बच्चे 12th क्लास पास करके मोस्टली फर्स्ट सेमेस्टर में आए, जो कहीं ना कहीं फैमिली के टच में थे, पेरेंट्स के टच में थे, और सीधा कॉलेज में शिफ्ट हुए, जो कि पेरेंट्स से अब दूर हो गए. तो ये प्रैक्टिकली हम देखते हैं जब बच्चे हमारे फर्स्ट सेमेस्टर में आते हैं कि वो रियल में वो एंजाइटी डिप्रेशन में होते हैं, वो बहुत सारी प्रॉब्लम फेस करते हैं. तो आपने टॉपिक बहुत अच्छा चूज किया है जो बच्चों का प्रॉब्लम सॉर्ट आउट कर सके.
Okay, good. So the topic chosen is good. Okay, quick comments. Yeah, we are.
It should be elaborated to PGs also, because I think in India, in Indian universities, PGs have more stress compared to first year students. They are more stressed. They have.
That's all. They say okay.
So that is very.
Okay, Dr. Anupama, the same thing, no? Say a little more kindly. See if you can say that. Try. Kushwant, you must include PGs also. What is, you know? I'm just pulling your leg. Go ahead. Oh, listen, hold on. Start again. Yeah. Go ahead, start.
I think that this is a very good topic and it should be practiced with PGs. It will be more spacious. Because they are more sufferers. Because they are having many kind of dilemmas, many kind of pressures. So
Right.
elaborate this study.
Okay. You saw the difference? No? The tone of the voice we use is very, very important. It is not what we say, it is how we say it. And it's really, and in our business as being doctors is so important. If you're a researcher, even more, because we are constantly communicating. I will add one additional layer, Dr. Anupama, if you don't mind. Okay, 1 second. Let me finish. I'll come to you. Hold on. One at a time. I'll give you all chance. So, Dr. Kushwant, this is a really nice topic, very timely, etc. Okay, and good. Please go ahead and do this. And may I request you to consider also including PGs, if possible in the study, if not in the next study. May I please request you to consider, right? So, it comes that way. And you know what happens with the first one, no? Why not included PGs? That means you've taken out your sword. What will Kushwant do? He's got 2 swords. Okay? Because he's got the podium there. Okay, he's got 2 swords. And when 2 people have open swords, there's only bloodshed. Nothing else. Okay, so when we communicate, and another thing, humans are extremely delicate. Okay? Somebody can be 6'6", big Pailwan, that person is the most delicate. Okay, and people who are aggressive, it's a defense mechanism for them. You think they are very strong, they're actually very delicate. So our job when we communicate is to build relationships, not. And the tone of the voice makes such a difference. So friends, I'm teaching you way beyond, or rather sharing with you what I have learned, which is so important, right? It's not what we say, it's how we say it, and using people's names. You had a comment or question, yeah, quickly.
Same thing, sir, that we Nimsian have this habit.
Nims?
Nimsian have this habit, so we.
Oh, Nimsians have this habit. Okay. Right, all Rajputs here, is it? With swords all the time. Right. No, it happens. Anyway, but I hope you agree with me, yes. Right? I hope you agree with me. Okay, also how we ask questions and how we answer. Okay, last comment, madam. Yeah.
So, Kushwant, it was very nice presentation. Your slides were good, and the background and the color you have chosen is perfect. I have 2-3 point suggestions, because if you want this funding for this project, you have to be very specific when you are giving references. So there is no mention of where these references are. You have not mentioned any references. So you should mention that. Secondly, though it is good to say anonymous, but the purpose of the study will be lost if you really don't have any track from where this information has come. So there should be some way of coding these subjects or the whosoever you are enrolling, so that if required you can decode it and find out who is the sufferer or where you really need any intervention, so that further studies can be planned based on the data you have accumulated. Otherwise you will have no information, you will have the data without linking it to from where it has come, because you made it totally...
Dr. Kushwant, one second, let madam finish. I'll tell you what to do. I'll tell you what to tell her.
Okay. And then if some flow chart can be made, I mean, you showed the methodology, yeah. So that becomes more clearer to the reviewers when they are seeing it, and again easy to fund. And then of course at the end of it, what will you do with the data has not been specified. So if you can somewhere mention how you will analyze the data and use it, whatever statistical analysis you may do it finally, so that will make it a good proposal. So these are my suggestions.
Okay, all you can say is thank you madam. So when people give suggestions, it's up to us to take it. If it is correct and if it is feasible, then you can take it, otherwise you need not take it. Okay, great. So yes, okay, last one please, quickly. Yeah,
Dr. Kushwan, that was a commendable job in a short time. You were able to do it well. But may I give a small constructive suggestion that in the title you have already clearly mentioned it is a privilege study. So I think we can avoid the word cross-sectional study in the title itself, because generally cross-sectional studies are done to estimate the prevalence. So it was just a suggestion from my side. In the title you can remove that cross-sectional study.
Sir, what is your take on this?
tell him thank you. Thank you. My take on it or what I leave is okay. Thank you. No. See, remember, my instruction was very clear, and this I have learnt and done in my workshops over many years. I learnt it the hard way also. The moment you allow people questions, there's no end to it. Because every word in this can be questioned. They didn't even have 24 hours like everybody else. You could not, and people who have prepared proposals for months together, lots of gaps in it. Published papers have problems, no? Peer reviewed, so no project is perfect. So now our job is not to show how smart we are or how much more we know. Our job here is to learn. That's all. Big round of applause for Kushwant and team. All these names. This is my wonderful team. Finished. People can see the names, right? Okay. The need for the study is usually a better way to use it. And then ideally you do a systematic review and say this is what is not known. If you have not done that, you need to indicate this is how we search the literature. I'll give you a nice phrase to use and the methodology also. We search the literature for the last 10 years. Bas, you want current prevalence, medical students. Because, okay, for the last 10 years from Medline, this and this. That's all. Okay, MBS is too expensive. Okay, Medline, we did this using the following keywords. We found 17 papers in India. Of that, this is known and this is not known. There has been no study in the whole state of Rajasthan. We are starting in Jaipur. Finished. Nobody will say, why did you not do Rajasthan? We're starting in Jaipur. That means we have a plan later on. Okay. So that's about literature review and giving references. I know you didn't have time. Okay. This is very valuable. Suppose in this slide you have 4 references. 4. Put all of those references here at the bottom in small font. In case people ask, where did you get that South American data? You know where it is. And when you write references, very important, and actually write this down, write only 3 parameters for each reference. First author, journal and year. Okay? Dr. Chowdhury, Lancet, 2004. Finished. Only 3 things. Okay? So that's there. Full reference can come at the end of it. Okay? Okay, let's move on. Okay, never write continued there on top. Write slide, okay, need for the study 1 of 2, 2 of 2. And every slide must have a title. Every slide must have a title. Okay? Mean prevalence, university students, okay, lack of, don't say the lack of data from India. I'm sure there are studies in India. Okay, but anyway, look it up later. Okay? And in any case, don't say lack of data. You say, I did this study, there is no study based on my search in the last 10 years.
We did not find.
Yeah. No, based on this, we did not find. Correct. Okay, and don't have long sentence like this, 4 lines. Okay, so we'll learn as we go along. Okay, objective I thought was quite nice. Okay, and okay, another thing, when you write objective, always start with to and a verb. To estimate, to assess, to and verb. Okay, a technical verb, not to do a study. Okay, many people say to do a study, to do a cross-sectional study, to study prevalence. That's just not a object. Okay, so here, does it have all the components of smart and finer? Look at it later. Look at it with a smart, fine lens later on. Okay, right. See here, to study the non-academic, to assess, to estimate. Don't say to study. Okay, in future. Oh, very important. In technical writing, never use etc. Technical writing, never use etc. You write. These are all the factors I'm going to look at. Okay. Okay. Methods. For where was I? Okay. So in a cross-sectional study, sampling is the #1 issue. I told you, right? Okay. So now you said first semester medical students where? Okay. In all the 9 medical colleges of Jaipur, mention 9 or 7 out of the 9, because 2 didn't give you permission. Okay, so that is called the sampling frame. Okay, I didn't use the word sampling frame before. So this is my sampling frame. One second, let me finish. Okay, this is the sampling frame. Within the sampling frame, how are you going to sample? Okay, so sampling frame you need to define. That means I'm not going to go beyond that. I'm not going to go to Udaipur, I'm not going to Jodhpur and Bikaner. I'm not going there. I'm here. Yes, your question.
As you told that mention all 9 medical colleges here.
Yeah.
Whether we have to mention name?
Need not.
Only 9 colleges.
Yeah, all 9 medical, for how many ever number there is? All 9 or 7 out of them. How many are there in Jaipur, by the way? 5. So mention that. 4 out of the 5 medical colleges. Or all 5 medical colleges. Okay, okay, let's move on. We don't want to spend too much time here, but critical things, let me tell you. Okay, so now the other thing is, when you look at a participant, this is a common mistake people do even in well written proposals. Okay, exclusion criteria, they'll say people who do not consent. That is wrong. Okay, the people you are considering are consenting medical students in Jaipur above the age of 18, and these days please write of any gender, because there is male, female and other. So please write this down. Okay, so writing, so consenting medical students of first year medical students from all medical colleges in Jaipur, etc., of any gender. Okay, so this last one does not apply in any study. Many people write that all the time. Okay, now personally, I don't know, you may have thought through this, and don't defend your statement now. This is what I am thinking of it. Why are you excluding people who are already having anxiety and depression and taking medications? They are part of the prevalence. That's how I look at it. Otherwise, your title and your research question should be those not previously diagnosed. And using a survey like this is not a great idea to diagnose. Okay, so your sample or your sampling frame should be those already diagnosed with or without medications, and those who are going to be picked up here. That's our prevalence. Okay, so think about it. Let's not argue about it. Okay, Google form permission. It's good to write ethics approval. Okay, so now you went to thank you. So let me tell you how you're going to analyze this. How to analyze this. So firstly, sample size. How will you estimate sample size for something like this? Based on what is already known. Okay, now if your prevalence is 30%, okay, so now here in a prevalence study you don't see study power, you look at precision. Usual precision is 5%, 7.5%, maybe 10%. That means the concept is like confidence interval. So you get a prevalence of 30, okay, and if your precision is 5, It's okay, your prevalence likely is 25 to 35, 5 on either side. That's what it means technically. Don't confuse it with confidence interval. It is something like confidence interval, but it's not the same thing. Okay, so so do a sample size estimation. Okay, then the next one is, let's assume your sample size is 600 and there are 6 medical colleges. Will you take 100 from each of the medical colleges? That seems to be easy. But if a medical college has got 250, another medical college has got 100, you need to sample according to proportion. Sample according to proportion. So you give weightage for the size of the number of first year medical students. Okay, so that means okay, so that's how you go about sampling. Let me not go into detail. Okay, how will you analyze this? So I would have liked the primary objective to have the following, including the title. Okay, prevalence and determinants of anxiety and depression in first year medical college. Determinants means what is causing anxiety and depression. Prevalence and determinants. Okay, friends. Okay, so now how will you find determinants? Odds ratios. And what is the meaning of adjusted odds ratios? So you will have this one is gone. The duster was here. Okay, doesn't matter. I'll tell you orally. Okay, it's okay. Leave it, Anurag. Okay, so academic factors you list out and you will collect it. Okay, did that. So you'll do regression analysis. But when we do regression analysis, you will tease out one factor at a time. You'll put it in the equation and see whether it was associated or not. Okay, so first you do univariate analysis. One by one you do. Write this down, please. Okay, univariate analysis is factor and the outcome. Factor and outcome. One by one you do. Next step, those that are statistically significant, you add all of that into the next model, into the next analysis, let's call it. Okay, and that is called multivariate analysis. So in other words, after adjusting for other factors, is this factor still statistically significant? And then you will make a conclusion. These 2 academic factors and these 4 non-academic factors were independently associated with, have you seen those words in journals now? That's what it means when you do adjusted analysis. Okay, friends, I'm giving you as much as possible concepts without going into all the formula and all that, and you can slowly get them. Okay, so that's what. So your conclusion would be, this is the prevalence, and the next question people will ask is, why there is so much depression? What is causing it? Oh, I'm going to do another study for that. No. This study itself, the title itself tells you prevalence and determinants of outcomes. All right. Okay, so your sample size and try to ensure that you have roughly at least 25% of each institution sampled. Okay, and then you have to account for refusal of consent and all of that. Okay, big round of applause to group 2. Well done. Okay, anything else I have to tell you? I wrote some notes here. Yeah, all of this. Okay, and I agree with Madam's point. I think you made the point about anonymized, no? Yeah. Right, so what if you get a very high score on depression there? This person is imminently considering suicide. Right, you need to track that. So we are ethically bound to do that. So and tell them, oh, this is how you deal with data, particularly things like this. You have to assure the ethics committee first, and then in your informed consent, tell clearly how you're going to handle the data. Okay, firstly it will be encrypted data that will reach you, so nobody can go in the middle and pull it out. And then once the data reaches here, what are the firewalls you have in your institution? I'm sure this institution has the world's best firewalls like we have, right? So you have firewalls, and then who is going to have access to that data and to that server? You mention all. Of course, you don't have to give all the technical details. You need to say that you're going to take care of all this. Okay, and that's about it. All right. Okay. Yes, please.
Suppose we don't anonymize this data and don't ensure confidentiality in the consent form, many students will not tell the truth.
That's there. That's a problem. That definitely is a problem.
Decided that we will anonymize the data, and like you said, maybe we can have a firewall and let somebody else look at it and pick the students who have a high risk.
Yeah, that's a possibility. Or no. Madam's point is, part of research is also well-being of our thing. You do this research, and in fact, oh, by the way, does this have any risk? Huge risk. You're asking people about their anxiety, they'll get more anxious. You're asking about depression, you're feeling all those things. Have you had thoughts of death? Is there in that? So that is a big risk actually. For people who are on the edge, as they call it, it's a big risk, and therefore they'll take the extreme step because of your study. Okay, so that's also there. Okay, let's move on, folks. So that was, so next, madam, is group 3. Group 3, group 2 spoke, right? This is group 3 now. Let us close this and give this a good shake. Okay, pick one. Are you in group 3?
Yes.
Oh, pick it up then. Pick your name.
Dr. Dawood.
Okay, good. Dawood. This bowl works, no? Like magic? Okay.
Good afternoon to all. I'm Dr. Rahul, and this is my wonderful team. And our topic is the evaluation of obesity as a risk factor for cerebrovascular accidents in the state of Rajasthan against control study. And obesity being a non-risk factor for ischemic stroke is not a new thing. However, the correlation of obesity and CVA in general, which includes hemorrhagic stroke also, is not known in the local population. There are not much
this is case control, no? Case control.
Considering both. And so the data is lacking. As far as we know, we have studied the papers of the last 5 years, and there was not much data in the domain. So the present study was aimed to find out any association between obesity and CVS in general, including hemorrhagic stroke. So our research question would be, are adults with obesity more likely to develop cerebrovascular accidents in general in comparison to those who are not obese? So our another hypothesis would be, there is no association between obesity and CVS in general. So coming to the objectives, our primary objective is to find out if there is any association between obesity and CVS in general. And our secondary objective would be to determine whether body mass index or abdominal obesity, these are the two factors which we will be measuring as part of our study. So which is a more reliable predictor of CVA, if at all any relationship exists. And coming to the methods, this is the study design is a case control study. Cases will be, eligibility criteria would be CVA patients attending OPD and IPD, that's not there in the slide, but OPD and IPD services in our institute, and patients of both sexes, patients of all genders, and patients aged more than 35 years, and with no prior history of cardiac or neurological comorbidities, and who are diagnosed with CVA and attending our OPD IPD services. So controls will be picked from other departments who are patients of more than 35 years, but who will not be having CVA. And continuous variables, like we will be assessing body mass index and abdominal hip waist ratio. So categorical variables will be blood pressure and pulse rate. So sample size calculation, we will be doing the sample size calculation, and pulse ratio will be calculated later on. And we have to take the clearance from Institute Ethics Committee, and ethical issues which can be there in this study is, if the patient is conscious and in a position to give valid consent, it will be taken from them, and otherwise we will be taking the consent from the attendants, and confidentiality will be maintained throughout. So approximate budget, so these are the things.
Right. Done.
Yeah, yes sir.
Importance of finding, next one. That's important.
So the prevalence and consequences of obesity among stroke patients are not being thoroughly studied. So obese survivors of stroke are more likely to have certain vascular risk factors, including diabetes mellitus, low HDL, cholesterol, hypertension, and obstructive sleep apnea. The association between total or abdominal obesity and risk for recurrent stroke or survival has been examined in only a few studies. So, post-stroke mortality is less in obese. This will be like once the study is carried out. This can be
important to find.
good.
Okay, well done. So that was group 3, right? So let's take a question. No, comment. Saurav, group A, group 1, Saurav. Okay, we finished. Dr. Deepak. Anupama. Go ahead. Comment, compliment, and anything to improve, value add.
So the study topic is quite good. It's a lot of conclusions which are good impact on the study topic, and yes, I find that if we can choose more complications, then it will be much better. And this study should be widened up. Means it should go on large size population rather than one centric, because obesity is a global issue. So if we can proceed, then we can find really very big, very better results, because the topic is very relevant and very means promising. Thanks for such a good topic.
All right, good, well done. So group 2, Mamta Yadav. Yes, your comment, please. Speak up from there, yeah.
Slides are good, sir. The way of presentation is very nice.
Talk to him. And what's his name?
Dr. Dao.
You know him well. You know him very well. So you give him good comment. Very good. Okay. What? Anything to improve the study? References. Okay, fine. Thank you very much. Take a seat. Let me ask group 4 for any comment. Dr. Rama Chaudhary. Again you. No, this is random order now. Okay. Go ahead.
I also feel the title is very good and the slides are nicely made. I like your background better than the dark blue. I feel it's looking more soothing. So I feel in the title, obesity is some way you need to define the obesity with BMI. When you are talking about inclusion criteria, did you define BMI anywhere? I did not see that.
I didn't expect that.
So that needs to be done. And secondly, I also feel that along with obesity, there are many other factors which may influence your outcome. So whether we can include that can be looked into, whether it is hypertension or cholesterol level or things like that, so they may be directly related. Then in the importance of study, the last sentence, stroke mortality is less in obese, can be put in a different way, because you have to bring out the importance of the finding. So not just stating the facts from that angle. And methodology also, can you go back to the methodology? So here also you can talk about what are the detailed tools you are going to use. That information is missing altogether. That what tools you are going to use for doing this study, or even evaluating the obese patient, or any other factors, so that can be added.
Okay, good. Anyone else who's got a comment? Yes? Okay. 3 comments. Okay.
Dr. Dao, you did a wonderful job considering that you had only 24 hours. So just a few things about this slide. So usually what I have been taught and what I follow is that these oblique lines, they create a little disturbance. White lines that you have got, or even videos and things, unless they are appropriate, they create a little disturbance. That is okay. They don't look bad here because they're not interfering with your text. But sometimes if they interfere in something else, then they disturb. So that is something. The second one is that regarding your controls, I wasn't clear whether your controls were going to be obese, non-obese, and how you were going to adjust for them. So you said there would be from other wards. And so what would you do about patients with stroke who were non-obese? Would you take them, not take them? That's something that needs to be done.
No answer.
I think.
Okay. Last comment. Yes, sir, Dr. Kushwant, you wanted to say something. Very brief, one comment.
Sir, it was a very nice presentation by you, Daud, and the slides were very nice. I just wanted to, this is a question.
No questions. Just make a comment or chai ke baad.
Okay, sir.
Okay. Okay, big round of applause for them. Well done. Okay. Here are my very quick comments. I agree with madam here. Firstly, on the slides itself, don't have any background graphics. Waste, and it's counterproductive. No background graphics. Keep it plain and boring. Only signal, no noise. No time for noise. Okay. Second, okay, so we don't have the evaluation of obesity as a risk factor for cerebrovascular accidents. Okay, so a case control study. So now my first thought that comes to my mind is, why are you focused on obesity alone? Okay, are you going to do another study for diet, another study for hypertension, another study for diabetes? Because you're going to collect all this, and so my favorite line for a case control design is the strength of association of risk factors for CVA in Rajasthan. Strength of association of risk factors. Okay, another thing if you want to add, strength of association of novel and emerging and established. 2 E's, emerging and established. Okay, because now you have some new biomarkers. You are looking post-COVID, you are looking pollution, you are looking all kinds of things. Okay, right? Look at that. And in places like Rajasthan, Delhi, etc., you have seasonal variations, no? Your winters are very different from summers, unlike in Bangalore, right? So you have extreme weather. So anyway, think about that. So look at multiple risk factors. Okay, so you're saying data lacking for the last 5 years. For things like this, you should go a little longer, 10, 15, 20 years maybe. Okay, the interstroke study was done. I'll come to you. Interstroke study was done and it has data on all of this. So look at that. You didn't have time for that. Yes, Mohit?
I was just part of the group. So the data exists from 2012. We saw data for 2012.
Right.
There is a reference that was given by vaccine.
It's okay. No, we are not justifying this study or clarifying which is right. We are trying to learn. So my point is more risk factors and a little longer referencing. Okay. Okay, somewhere you said whether BMI or abdominal obesity is more reliable. There are different ways to measure abdominal obesity, and the easiest way is waist to hip ratio. Okay, but there are other methods also to look at that. Okay, now when you come to eligibility, where is eligibility? Research question, let's look at this quickly. Adult more likely to compare obese. Okay, madam, just remind me about matching, whether about, in case I miss out, just remind me, I'll tell you about that. Okay, secondary, okay, we'll skip this part. Okay, now in a case control design, you need to write eligibility criteria for cases separately and control separately, and the key difference would be control definitely does not have CVA. Should the control be obese or not?
Yes. No, we are not controlling that.
That is the whole idea. So you do not go looking for obese people, or you do not go looking for non-obese people. Okay, so that's how we, okay. Right, and another thing, matching criteria and matching ratio. Cases and controls 1:1, critical to write. And what will you match on? Just age and sex, as I told you. Okay, don't match for anything else. So if you match for more than what is absolutely necessary, it's a problem in case control designs called overmatching. Let's not have that. Okay, so sample size, how will you calculate sample size for this? You look at previous studies And if you are particular about obesity, what is the odds ratio they got for obesity? 1.7, 1.8, 2.1, what did they get? Okay, based on that you can calculate sample size. Okay, right. Okay, those are the things, and the confidentiality equipment. Okay, importance of findings is not this. You find risk factors, how is it going to be useful? Okay, so in other words, importance of your finding is what can you do about it? Think about what you can do about it. All right, so shall we move on? Anything final? So what is the next group, madam?
Group is, that's on the previous.
Group one. Group one has to present, right?
Yes.
This one is group 1.
Oh, this is group 1. Okay, we need to. Okay, we have to fold it a little bit more. Once more, we have to fold. Okay, who's going to pick? Here. You pick. You are busy looking at the clock.
Saurabh.
Okay, Saurabh, come.
The topic is evaluating the program impact of cardiovascular incidents in individual exposed to second-hand smoker, means passive smoker, and observational score study conducted in Rajasthan. The active smoking is an established fact for the cardiovascular event. A few studies have reported the risk of leaving the active smoker. Occupational smokers are prone to cardiovascular disease also. So in India there is a 5.2% prevalence of cardiovascular disease. So that's why we are thinking to do a study in Rajasthan. Actually there is less data in Rajasthan. So we are trying to focus on this topic to find the prevalence or incidence of cardiovascular event in non-smoker. This is the literature review. So the aim of the study is to provide the valuable insights into the long-term burden of cardiovascular incident among individuals who are not active smoker but are exposed to harmful effect of tobacco smoking. The primary objective is to assess the long-term burden of cardiovascular events among individuals exposed to passive smoking. The secondary objective is to evaluate the confounding factor for the cardiovascular events in adult passive smoker, to evaluate the rate of MI in adult passive smoker in Rajasthan. Our research question is what is the extended burden of cardiovascular events among the passive smoker in the region of Rajasthan, and how does the long-term exposure contribute to the prevalence and severity of cardiovascular incidents. The null hypothesis passive smoker are less prone to cardiovascular events. The study will be conducted in Nims Hospital. This study will compose both the urban and rural population of Rajasthan. This is prospective cohort study. Duration will be 5 years. The inclusion criteria, both the gender, the age criteria between 18 to 80 years, who diagnosed with CVA, who have family history of smoking, but who are not. The participant should be non-smoker, and those participants who are willing to participate by consent, by signing the consent form. Inclusion criteria: less than 18 years, active smoker will be excluded, and those participants who have comorbidities. Investigation: lab investigation, C-negative protein, total cholesterol, lipid profile, CBC, cardiac biomarkers, SHS questionnaire. This is the gold standard method for detection. CVS, second-hand smoke exposure scale, SF12 questionnaire for health-related quality of life. This is the consent form. The participant patient will be briefed about the study procedure and informed consent form according to the appropriate guidelines will be signed by the patient before their enrollment in the study. This is the confidentiality. Efforts will be made to ensure participant confidentiality through the anonymization of data, ethical approval from the relevant ethics committee vote will be sure. This is the participant recruitment. Study will be collaborate with the local health authorities, community center, health provider for participant identification. It will be used as a standardized questionnaire to assess the demographic information, smoking history, cardiovascular risk factor, by obtaining informed consent from eligible participants. Regular follow-up will be scheduled to collect the updated information on smoking exposure, lifestyle changes, cardiovascular health. This will involve implementing standardization questionnaire and health assessment during the follow-up. The withdrawal criteria: if the patient is willing to stop the interview at any point of time of data collection, if the patient develops any serious comorbidity or any condition. This is the reference.
Okay, good. So that was group 1, isn't it? Okay, let me pick names from here. This is Bhumi Chaturvedi. Yes. Oh, you picked his name, so you got a question. Go ahead.
Hi, Dr. Saurav. A very nice presentation. My suggestions, I was not very clear about the objectives, so this was my suggestion. Thank you.
This is, sorry, don't feel bad. Okay, this is when you talk a lot and say nothing. Correct, at the end of it. Okay, so anyway, so at the end of it, Saurabh and team did not get anything from you. Don't feel bad. I mean, this is what happens. So I missed out telling you people, to give comments, you need to see how many comments I wrote. You need to keep your pen open, your book open, mind open, constantly look at it, keep on writing. Keep on writing, then you will get. You can't suddenly think of something. Okay, next person should do a better job. Mansi, yes, Mansi. Rather than not there, can you try saying, it will be nice if you had included?
Yeah, it would be nice if you include a name for your study. And you said it's a second-hand smoke area. It is not clear which all type of second-hand smoke you have included in the study.
So it's not clear. What do you want them to do?
You make it clear to where they are getting exposed to the second-hand. What are all the things they are giving them second-hand? So it could be due to pollution or due to the cooking and smoking, whatever it is. And industrial smokes and all, you have to clear it about what type of second-hand smoke they are getting exposed to. And funding, it's not clear. And last.
Okay, no, the funding part, no? See, again, we are learning to communicate here. Rather than saying funding is not clear, I would recommend that you mention at least 1 or 2 potential sources of funding for this presentation, right? These are the ICMR, maybe DST, DBT, whatever. Or maybe Indian Tobacco Company can fund it as well. Right? So, is it ethical to take funding from them for a study like this? Right. So medical institutions should not take funding from tobacco companies, alcohol companies, and things like that straight away. Okay, that is one. Pharma companies is carefully done. You can take, and also in my session on grants, whenever I do that, I will tell you that there's a difference between marketing and medical foundations in pharma companies. Foundations have large funding, you can take from them as well. Anyway, thank you, Dr. Mansi, please sit down. Anyone else? One quick comment, one final. Oh, so many hands. Okay, her voice. We haven't heard her voice. We've heard your voice enough, including from the podium. Go ahead.
Sir, it was a very good presentation. Nicely made.
Sir का नाम बताइए ना.
Saurabh, sir.
Yeah. Oh, you told? Oh, sorry, I didn't hear. My apologies. Okay, go ahead.
Very nicely made. My suggestion to you would be that when you're talking about the follow-up training, you could mention
Gaurav. He is from research and innovation. It's okay.
All right, good. Good point. Go ahead.
Dr. Saurav, it was a nicely designed slides. It was very catchy and beautiful to see the slides. But may I give some small suggestion that to increase the visibility or like to the readability of the letters, you could have made the sentences bit short, and like there is a pattern that like 6 by 6 lines and 6 points in a single slide, so that it would be readable for everyone, even sitting at the back.
Okay, good point. All right, so big round of applause for this group. You can go back. Okay, my quick comments or take on this, starting from the title, okay, or starting from the fonts in the title, preferably not to use sharp edged fonts like this. Okay, so use rounded fonts, whatever you want to call it. Okay, preferably. Okay, very commonly people write a study of the, such a waste of words. Okay, recently we submitted a big grant. They are giving you characters, not number of words, number of characters in each section. Title 75 characters, objectives 250 characters, 251 the software will not take. Okay, so be careful. So write a title, keep chopping, all that is not necessary, chop out. So here, okay, the next issue that I had here is, what is cardiovascular incidents? Cardiovascular incidents can be heart attack to brain aneurysm to cardiac tamponade to strokes to peripheral vascular disease to mesenteric embolism. Everything is cardiovascular. Okay, so be specific in your outcomes. There is a big difference between between these three. Tubercular pericarditis is also cardiovascular event. Okay, at the end of it. So that, okay, then you have to clarify second hand smoke, although generally speaking it is tobacco smoke. Okay, now there were comments here about what kind. I think Dr. Mansi was asking, what smoke are you talking about? Indoor pollution, outside factory pollution, or factory smoke, or general atmospheric pollution? That to be clarified. Okay, so those are two key things. Background, yeah, long sentences better to avoid. References, so rather than saying background, what is this literature review? Oh, okay, please avoid this, putting whole things over there. So put one key sentence there and add a reference at the bottom. Okay, better to avoid these things, although people tend to use this. Okay, so and by the way, many times when you come up to present, they'll give you slide number limit also, 6 slides, 8 slides, then we are in trouble. Okay, study aim, objective and hypothesis. Aim to provide valuable insights, long-term burden, who are not, okay. So assess, oh dear. Okay, so this is a big problem. What is the meaning of long-term burden of cardiovascular events? So what are we doing in a cohort study? Unfortunately, I didn't do the lecture for you all. We are in cohort study. The beauty is multiple risk factors, multiple outcomes. Multiple risk factors, multiple outcomes is what you get. Okay, so think about this. Think about what we could do better. Let me move on to a few key issues here. Null hypothesis, all that is fine. Studies cite both urban and rural populations of Rajasthan. Prospective, okay, we need to tell where will the patients come from and how will you sample them, and what is your definition of cohort is there in eligibility, I think. Inclusion, okay. So participants aged between 18 to 80 years. Suppose one person comes 81, will you exclude that person? So better not to have an upper limit unless there is a compelling indication. I don't see a compelling indication here. Okay, clinically diagnosed with CVE but not active smokers. So they already have an event, cardiovascular event. So what are we looking for then? An additional event? Maybe. So then we have to clarify that. Okay, either an index or a first event or multiple events. Family history of smoking. Now, this person could be 50 years old. Father could have been a chain smoker. He's not living with the father anymore, or the father is not living anymore. Family history is for genetic issues. okay, which never changes. Okay, so alternatively, you need to say that these people have, and by the way, so you're measuring exposure in different ways, right? So remember, exposure, no exposure, outcome, no outcome. You'll have all 4 options. So don't fix yourself on saying they must have an exposure to smoking. Okay, then you are not able to measure no exposure to smoking. Okay, then patients are willing to participate, fine. Participant should be non-smoker. That's fair enough, because you're talking about second-hand smoking. All right, that's fine. Then in your okay, participant, this is another thing, exclusion criteria. This is a very common mistake again. Your inclusion is above 18, exclusion is less than 18. Okay, inclusion criteria, prostate cancer. Exclusion, all women. I won't exclude them. You got this. With this, you should not make this mistake again. I'll give you another example. Ovarian cancer, you're going to exclude all men. Okay, so you got it. Within ovarian cancer, which only women get, what do you want to exclude? Okay, so with these 2 examples, you should not make this mistake again. Okay, active smokers with any CVE. A little confusing. Okay, and why participants with comorbidities? Rheumatoid arthritis these are all covariates. If it is important, if it is in the line of the pathophysiology, you adjust for it, because covariates is a very broad criteria. Okay, study tool, this is fine, this is okay, I will recruitment. Okay, now what is missing here for me is the duration of your cohort. Very important, duration of your cohort, and sample size. How will you calculate sample size and how will you analyze this? Okay, since we did not do the session on sample size fully, I'll tell you. Okay, here again, what do you want to estimate? What is a reasonable risk level to estimate? 50% additional risk, so that means you want a relative risk of 50%, you want to look at it, then accordingly do the sample size and the analysis. Okay, confidentiality, all this is fine. Okay, withdrawal criteria, this is the last point I want to make here, I think. Withdrawal criteria, if patient is willing to stop, that is okay. So that is during consent itself. And then in your protocol you write, if I don't get so much of data, I will not include it in the analysis. What if patient after giving you 10% of data says, I don't want to talk about all this? No need to include that. Okay. Next, if the patient develops any serious comorbidity condition, why you want to withdraw them? Include them in the study, continue. And if they are able to continue the study, continue, because they can have other events later on. Okay friends, that's it, done. So once again, big round of applause to this group, very well done. Last one is which group? Yeah.
You and Dr. Kochar are supposed to go together to the airport.
Yeah, you pick. You've been very close to the bowl. Oh, you got 2. Okay, that one you read.
It's empty. This is also empty.
Wow.
Empty?
They put empty. Anamikas. These
Anurag.
Anurag.
Very good afternoon. And myself, Dr. Bharathi, going to present topic. Capox versus Colpox treatment in the first-time management of stage 4 colorectal cancer, a randomized controlled trial, and this is being study conducted by the 13 members of Group B. The introduction about the study is that stage 4 colorectal cancer poses significant challenges and requiring effective and well-defined targeted treatment strategies to enhance the patient outcomes. The Capox and the Colpox regimens have shown efficacy in the treatment of advanced colorectal cancer, but comparative evidence is limited in the Indian population. The reason of selecting this topic for the study is that the clinical significance of the stage 4 colorectal cancer represents an advanced and metastatic disease stage with limited treatment options. Patient outcomes, that understanding the safety and efficacy profiles of the treatment regimen A and treatment regimen B. Study comparing the Capox and the Colpox in Indian population is limited, and majority are retrospective studies, and we are going to do it as in RCT. and this will be in the first RCT in comparing the two regimens. Our research question is that among patients with stage 4 colorectal cancer, does capox is better than Folfox in reducing the deaths and the side effects over the period of 1 year, and the aims and the objectives of this study are that the study aims to compare the safety and the efficacy of capox and the Folfox in patient diagnosed with stage 4 colorectal cancer, and the primary objective of the study is to compare the efficacy between capox and Folfox regimens in patients with stage 4 colorectal cancer, and the second objective is to compare the safety between the regimens. The following hypotheses are being formulated. The alternate hypothesis that there is significant difference in the safety and efficacy outcomes between treatment regimen A and treatment regimen B in patients with stage 4 colorectal cancer, and the null hypothesis that there is no significant difference. The knowledge gap which we found for selecting the topic is that the presented studies collectively contribute valuable insights into the various aspects of cancer treatments, including adjuvant chemotherapy regimens, neuropathy, and quality of life. However, the comparative knowledge gap exists in the lack of comprehensive exploration into the long-term effects and quality of life implications of specific chemotherapy regimens, such as capox and Folfox on the cancer survivors. We have read the literature review and found that there is a need actually of conducting the study on this topic. These are certain of our studies. The methodology which we are going to include for the inclusion criteria, that we will be including the histological confirmed stage 4 colorectal cancer patients aged between the 18 to 75 years and are of Eastern Cooperative Oncology Group performance status. The exclusion criteria that the individual below the age of 18 are not eligible to participate in the study. Patients who have undergone prior chemotherapy treatment and excluded from the study. Individuals are unwilling or the recruitment will be that eligible participants are admitted to medical oncology department of Dr. Balbir Kumar Cancer and Research Institute will be randomly assigned to either arm A capox or arm B Folfox in 1:1 or 2:2. A stratified randomized block design will be adopted to assign the patient, and the decision factor included P5 and number of metastatic sites based on this will be reported. The intervention explanation includes that the arm A, that is experimental group, that is capox, will be having given twice daily on days 1 to 14 days, and oxyplatin administered interventionally on the day 1, and for the 3-week cycle it will be followed. The arm B, that is control group, that will receive the Folfox, and 5-fluorouracil administered as a continuous intervention infusion for 4 to 6 hours on days 1 to 2, and oxaliplatin administered intervention on day 1, and the glucocorticoid administered intervention on day 2, 1 to 2, 2-week cycles. The follow-up will be done for the treatment duration, pre-treatment assessment, cycle given assessment, imaging of response assessment, and the response criteria and all. The population for the sample size, the population sample size will be calculated by this formula. The statistical analysis actually that is for primary outcome, that is progression-free survival, PFS at 12 months. PFS was defined at the time from the date of randomization to the first documentation of the disease progression. Kaplan-Meier curve for PFS and secondary outcomes for the adverse events will be noted. Here the data collection will be conducted in compliance with the ICH GCP guidelines, and the study will also be conducted in accordance with the most recent version of the equation of Helsinki. The investigator is responsible for ensuring that all the sections of each CRF are completed promptly and correctly, and the entries can be verified against any source data. Study movements will perform source documents over verification, identity, and consistency between the auxiliary source documents. Description will be resolved in accordance with the principles of GCP. Detailed study, monitoring, procedures provoked in clinical monitoring, done as well as coded with the most current available version of MAT-ER. My study plan phase 1. Actually, phase 1 is the detailed literature review will be done in tertiary sources, secondary and primary sources, then designing of the data entry from the informed consent and consent relationship. The study will be persistent to IFC for the approval. In the phase 2, the subject will be enrolled in the study, which comes under the inclusion, exclusion criteria and willing to participate. Informed consent will be taken from the state subject, and phase 3 reports will be analyzed and documents will be presented to the partner. This is the copy of participant information sheet in the English and in the Hindi version. This will be the withdrawal criteria, that any participants who decides that they no longer wish to continue in the study and revokes the informed consent. Any participants who experiences severe side effects or health complaints directly linked to the study interventional procedures should be promptly withdrawn. Then if the participants' health worsens to a point where continuous participation could compromise their well-being safely. Thank you.
Okay. Okay, I'm not picking any names. 1 or 2 comments. Anybody? Yes, go ahead. Okay, sure.
Dr. Maharaj, it was such a nice presentation. I really liked the slides and the graphics you have added. I was searching for something which was missing, and it would have been nicer if you would have smiled during your presentation.
I think that's a very nice comment.
You made him so tense.
There was lot of information, and it is good to have information, but if it would have been conciser, then it would be easier to memorize. Methodology is up to the mark, and this is the first presentation in which detail about the statistical analysis has been given, so that was commendable. Then there was it would have been better if data collection would have been prior to the statistical analysis. There was some jumbling of the slides. And sometimes there is a time limit or a time frame. So this much number of slides can be a challenge to present if you are applying for a grant.
Okay, good. Thank you, Dr. Kushwant. Take your seat. Anyone else? Quick comment.
I observed some grammar mistake like was.
Tell him.
And some places you have mentioned was maybe in the.
Yes, I also.
Okay.
And at last that slide quite at last
Okay, got it. Yeah.
So, Dr. Maharaj, excellent presentation. So, just a few things that worried me, that you have a randomized control trial, and which means that both the groups should have similar timelines, similar everything. So, you would have had to have a placebo somewhere. I don't know whether in this study there would be something, because your frequency of administration in one group is every 3 weeks, in the other group is 2 weeks. The total number of cycles is different in the 2 groups. So I really don't know how to handle this, and that was just my comment.
Okay, good. Well done. Thank you very much, Dr. Maharaj. You can go back.
Because that I also had the same query. The treatment regime is like that.
No, I didn't say that. I said I know the regime is like that. How do you adjust during randomizing?
Okay, we will come to all of this. Okay. All right, my final comments, my final input for this course. So before we make a comment saying that this is the first study, etc., being done, we need to qualify it in the sense, how did we know, how sure are we? Then when we write inclusion criteria, where do we go? I'm going to skip all this and go straight to inclusion criteria, literature review. Again, better to avoid this. Okay, again, okay, inclusion criteria. Okay, histologically confirmed stage 4 colorectal cancer. So that means whether they are active, whether they were treated, whether surgery was done, not done. That means, so clarify that condition, number 1. Number 2, again, why 75? Colorectal cancer happens in older age. If patient is 76, or will we do a trial for 75 to 95? Okay, so keep that in mind. It's a common thing that we have, and I strongly feel we should not have an upper limit. Okay, that is one. And please also mention gender. This is colorectal. It's not prostate or ovary or uterus. Okay, so that one. And also, once again, to tell you, you can say, and many times people say male and female patients are eligible. Very rarely you get male and female in the same individual. Very, very rarely. You'll not, it's an extremely rare occurrence. Anyway, so always say male or female are included. Okay, can be included. Even better to say any gender. That's it. Okay, so this is one thing for the, I have already said this, eligible, undergone. If they have undergone prior chemotherapy, anything. Okay, that's fine. Okay, all this is technical. We'll leave that out. And okay, so madam, coming to your question of when you have differential regimens, they are treated like that.
Yes.
Only two options. One is to have a double dummy design. Okay, maybe another time we can discuss what a double dummy design, just to answer or address your concern. The other thing is you are looking at survival. Doesn't matter if it is open without being blinded. You are looking at survival. So for survival, you don't have to worry. Every soft outcomes other than hard outcomes, you can have it as an open trial. Okay. So no worries about that. Okay, and so somewhere, I hope that was clear for you. Yes. Okay, so now here, okay, what is this now? This is sample size for what? This is sample size for prevalence. Okay, as I can see. So the principle for sample size estimation in a trial is knowing the effect size or estimating the effect size. So in this group, this is the event rate. In this group, this is the event rate. So there will be two. There will be A plus B. So even without digging more into the formula, I can make out this is not the right one. Anyway, so look it up. So that is the principle. And analysis, you can look into it. Somewhere you had phase 1, 2, 3, 4 is very confusing. This one, when a clinical trial. So you can say step 1, step 2, step 3, etc. Okay. Right. So this is what I wanted to tell you. Recruitment, consent, etc., etc., etc. Withdrawal criteria. Okay, right, so let's blank that out. I really have to run if I have to fly, or I have to fly in other words. So my sentiment over here, 1 or 2 minutes I will take. My sentiments over here is once again gratitude. Thank you very much. As you can make out, since yesterday to now, 90% of the time I've been talking. Do I look tired? I can go on for some more time. It's only because I am motivated. I'm not a superhuman being in terms of physical abilities. Okay, my only motivation or my driver is to share the little knowledge I have so that you people can do a slightly better job or a much better job, whatever you want to have a challenge for yourself, to do better research, eventually to benefit humanity and the planet. Okay, we'll add planet over here. So I've had fun coming here. I came here last year. Hopefully I will come here again if you invite me, or not hopefully, I'll be delighted to come here again. So thank you very much. All the best. Take care and God bless you. Bye.
So I think we come to the conclusion of the meeting. And first of all, I have to thank my old friend, Dr. Xavier, who has come all the way from St. John's, and we have been at different panels and forums, and he has been visiting my parent institution, that is AIMS, I think many times. I don't know, 15-20 times he must have visited. From very beginning, actually, he has been coming since I was there. So it's a great honor, and pleasure to welcome him and to see through the conclusion of this particular session that was organized. Next, I have to thank Ma'am Dr. Rama Chaudhary for all her initiative and all her efforts, ultimately getting it done. And I think it was a great thing for our university, for especially the medical streams and sciences streams, which I am sure benefited greatly with his deliberations, Dr. Denis's deliberations, and Dr. Shobna. She was a constant help and inspiration to all of us, and Madam has been here and helping us organize this event and also disseminating her acute wisdom in all these areas. So I think I thank her, and I also thank Anupa Madam. She was, I think, the key person who organized everything, and I think a big clap she deserves. Thank you, madam. And also I have to say that Dr. Mahavir, who is our research head, also helped, and he was instrumental in getting all these things together. And then I think, but the most thankful I am to you, the delegates who have come here and you have participated in this very interesting deliberations by Dr. Xavier, and I came to know that there were a lot of funny moments as well besides learning, and I think that's the best way to learn. So he has a unique style. I have witnessed it before. We actually in our cardiology society also, I think some time back, organized something like this, and so at that time I was one of the organizers. So I was witness to his skills there, the soft skills of communication in a way that you can all learn. So I'm sure all of you would have benefited, but most of all because of your interest. I think before Dr. Denis, I am nothing, but I still have to say why we go for research. You might say, okay, because my appraisal form will look good, or you might think that, okay, my publication will be there, I will get known, etc. But I think the most important thing why we should go for research is design thinking. So this is the thing that you learn once you do a research. You start from the background and you move on to aims, then material methods, statistical discussion, then results, which is the actual thing, then discussion, and then conclusions, and then you publish it, and so it involves a whole lot of design thinking. And I think in the era where number of jobs will get less, it is the design thinking that will work, because then you can have your own business, or that's what is entrepreneurship. So that is, I think, this is the beginning of entrepreneurship, doing a good research. And so this research attitude, that is why it is very important, because we know that the number of jobs will not be enough for number of people who are coming out of university. The aim of the world global bodies is that 100% primary education and more than 50% higher education. But the problem is, if you get more than 50% higher education, all of them will not get employment in the offices. So they have to do their own thing, and that is why entrepreneurship is important. And research is the best way to learn entrepreneurship and best way to learn design thinking. So I think that is why in life it is very important. My request to you is that you have sort of got into this thing. Now you have to pass it to the students, because we want all our students to design think. And I think this is the main thing. And sorry, I think taking more time from Dr. Xavier, he has to rush. So again, I will say thank you very much, and of course to the Nims University and the management who made it possible.